5358. Now, let me repeat that. And it doesn't say that on the teleprompter, by the way. I'm just actually repeating it on my own. Call-in number, if you want to be live, in case you're driving and you don't have access to just seeing it, is 832-239-5358. And then if you check out the scroll bar down below, which is going to come across, and that sort of stays there, I think, during most of the program, you can find all of our social media information. You can find out our contact information. Our call-in number is in there. And just for those who may have not gotten the last numbers, 832-239-5358 to call and be live on the air. Would love to hear from you. But all of our information, please go to the YouTube, go to the Twitter, go to the Facebook, go to the LinkedIn, go to these places and do whatever it is they do. Like, follow, share, click, make comments. Comments, absolutely, comments are the most important thing that we can get because that is how Google rates us. What'd you say? We need feedback as well, of course. Yeah, because we need to know what we're doing. But at the end of the day, Google really looks at that, or any of the search engines, and they take into consideration the number of times people comment, and that moves you up in those rankings. And it's just very important to us and this channel, and we would appreciate that very, very, very much. I want to take a minute and talk about our MediWeb app. I think we have finally gotten to a point where, and you can find this on the Google Play, you can find this in the iStore, the Apple Store, or whatever, you know, whether you use Android or whether it works in both iOS and Android. So why don't we just go to it if we can. So I'm going to show you the app. Here it is on my phone, and that's my phone right there in the screen. So you see, well, no, that's not my phone. I've started it like 3 or 4 times. I could start it again. There, start broadcasting. I don't know why it stops. 3, 2, 1, and there it is. Now it's on NDI. Okay, there, you can bring it up now. And there we go. There it is on my phone. I put it on its own page. So you click on and there's 2 apps. There's a critical care perfusion app and there's an IV MedCalc app. The IV MedCalc app is really great for nurses in the critical care unit, and it's a standalone app. It does a lot of different stuff, but it's in the critical care app. That single app, the IV MedCalc, I'll do that one first, is only 99 cents. But it's an IV dosage and rate calculator. So if you had IV rate at milliliters per hour, the volume was ordered was 500 cc's. 500 cc's. And the time administration, you want that is 180 minutes. Quickly calculate 166.67 milliliters per hour. But if you had dosages you were doing, it becomes a little bit more complex. And you can see that it does nanograms, micrograms, milligrams, grams, units, whatever it may be. The patient's weight, either in kilograms, pounds, or grams. So it's appropriate for pediatrics as well. And then your volume administration in milliliters or liters. And there's different things that you can put in here and get some very rapid calculations. I think it's a very beneficial app. Then there's also the, I need to get out of that one. And we'll go to the critical care perfusion app. And let's just say you get to the hospital in the morning, you're going to do your case. We have the very first thing you see is Perfusion Quick Calcs. You click on that. You're going to pick, it's a male that's, and it's based on, the volume is based on 75 mLs per kilogram. If you pick man, the age of the patient will say is 65 years old. The patient's pre-op hematocrit is 37. The patient's height is 180 centimeters. Patient's weight is, we'll make it a standard 100 kilos. The pump prime is going to be 1,000. The anesthesia volume, that's probably going to be 10 liters. We'll say 1,000 as well. Pre-pump urine was 300 cc's. The heparin dose you're using is 300 units per kilogram. Calculate. And by the way, you can pump prime. You can adjust that if you're going to wrap or anything like that. 1,000 cc's, probably fairly generous. But here's the information it spits out at you: is BSA, BMI, estimated blood volume in milliliters, red cell volume, heparin dose, estimated on pump hematocrit, and what your protamine dose would be, and then your calculated flows from 1.6 liters per meter squared all the way up to 3 liters per meter squared. So you put the basic information in and you get all of the stuff you need for your chart right there at your fingertips. If you're on pump and you want to know what your delivery is, obviously you're going to have to know your cardiac output, so you're flowing 4 liters per minute, and let's say based on that hematocrit you have 16 milliliters per deciliter, your arterial oxygen content 16. You could see your DO2 is going to be 640, maybe a little low. You may be okay with that, maybe short term, but if you wanted to get that up, you're either going to have to increase your CaO2 or you're going to have to increase your flow. Generally speaking, on bypass, it's harder to increase your flow because the heart doesn't drain as well and everybody having a bad day. If you want to know what your O2 transfer rate is, you can put in your SaO2, which is 95%. Let's say in this case, your SvO2 is 76%. Your hemoglobin is, we're going to say, 8, and your flow is 4,000 milliliters per minute, so you do have to pay attention to that. Your O2 transfer is 81.47, so you can determine very quickly whether or not your oxygenator is or isn't working. You can calculate collar oncotic pressure. You can do adjusted body weight. And this is kind of neat, and this exists also in the, I think this is just such a cool app. This exists also in the ECMO section, which we'll quickly look at. But if you have an E-cylinder, and you have 900 psi and you're flowing 4 liters per minute of oxygen, you have 78.16 minutes remaining. So roughly 78 minutes, 70 minutes. So if you're transporting someone and you look at the tank and you see you have 900 in your 4 liters, you know you've got time. On the other hand, if you're at 8 liters for whatever reason, you only have 39 minutes, so it's going to shorten that time quite a bit. You want to make sure that you get yourself to where you need to be within a reasonable, or get another tank. You should always have a backup tank, right? But we don't always. Sometimes you just got to look. There's some nomograms, estimated blood volume by weight, calculated blood flow rate by BSA, and safe circ arrest times by temperature. They're remarkably very short, as you could well imagine. No amount of circulatory arrest is good for anyone, but statistically speaking, there are ranges where it may be safe. There's ECMO here. You can see everything that you have. You can look at your PF ratio, oxygen consumption, extraction rate, O2 transfer, oxygen delivery, and oxygen delivery index, an ABG interpreter there. So if you wanted to know if it's respiratory acidosis, metabolic acidosis, or mixed, or respiratory alkalosis, metabolic alkalosis, you can do that. Clinical calculators, OR fluid requirements, NPO loss, allowable blood loss. And that's really a neat section of the app we just recently did, because now you can say the patient weighs 100 kilograms, initial hematocrit is 35, and you want the lowest desired hematocrit to be, very few apps do this, by the way, lowest desired hematocrit to be 28, you can lose on that patient. The average blood volume is 7.5 liters. Allowable blood loss is 1.5 liters. And what that means is if you bleed 1.5 liters and you give back non-heme, albumin, saline, whatever, your hematocrit will drop from 35 to 28, and it tells you that very quickly. So that's a very useful part of the app. And then, of course, there's the IV calculator I talked about, and conversions. hemodynamic monitors. You want to know your mean arterial pressure. You can put in your systolic, diastolic, and get your mean arterial blood pressure very quickly. Your SVR as well, systemic vascular resistance. Plug it in. Mean arterial is 70. CVP is 10. Cardiac output is 5. And your SVR is 959. You notice it's green because it's normal. So anything within normal limits will be green. Anything outside of normal limits will be red. So if I go back up here and I give this patient vasoplegia, you see there that the color changed. So very cool. It's $2.99. It is our app. We are selling it. I'd love to sell 1 million copies of it. Magic, how far are we away from 1 million copies being sold? 900,000? Okay, now that's a lot. We've sold 100,000 of them, have we? No, I didn't think so. No, I think we've sold maybe 1,000. We need to sell a lot more. Okay, so we can take that down. And then the other thing that I want to do is talk about our podcasts. Our podcasts have become very popular, actually. And I think we're streaming podcasts simultaneously now. So I think that's what I think. Is that right, guys? Do we stream the show's podcasts simultaneously? Yes, we are. So this is live on podcast as well, which is pretty cool. But you can go to whatever your favorite streaming site is. Spotify, I guess, and Podbean or Podbeam or whatever it is, Apple, Google, and so forth. And you can just look up PerfWeb and you'll find us there, and you can listen to us in the car. And if you want to call in from the car, you can call in from the car. If you hear me say something that you have a question about, clarification, correction, it doesn't matter what it is. Love to hear from you, right? And then I also lastly want to talk about some new technology, the social media pop-up that we have that will allow us to take live comments and be able to display them during the show. Like this, good morning from PerfuseFind, our friend. That's fantastic. So it actually does work. And I'm really excited about that. Now, it says it twice, the PerfuseFind. I don't know if that's just a glitch in the system. That's their name? Okay, PerfuseFind. That's just their logo. And but that is really cool. And good morning, my friends. They're from Spain, right? Spain. Yes, our friends from Spain. Good to see you. All right. Well, I think we can get started. What I'd like to do, if I can, let me grab a sip of coffee. Okay. And I am going to start my timer and come over here to the front and go over some stuff so that I can keep track of what I'm doing here. Okay, fantastic. All right, so since January, and we talked about it actually last year as well, but since January in earnest, and believe it or not, it's really taken us this long to do, but we have retooled the studio in order to bring you as realistic as possible in a virtual world ECMO simulation. So historically, traditionally, and probably much easier is to do ECMO simulation on site at a place and be able to do it. But we have seen so much incredible uncertainty over the past few years with COVID that at any given moment, we could not be together or being able to be together. And there's a lot of people that just simply can't travel, don't want to travel. It's time, it's budgets, it's all. That's the whole purpose of PerfWeb. The whole point of this is to try to bring a meaningful education program to the virtual audience anywhere in the world and be able to do it in a polished, professional, sophisticated, and fun way. We're all learning together. I know you guys have been incredibly patient. Some of our programs have exploded. I don't know if David has the fire, but sometimes our programs feel a little bit like this. I don't know if he could do it or not, but let's see. Yeah, that's sometimes about what it has looked like. Okay, we can move on from there, and I appreciate that. And sometimes, the program is turned into the my favorite animal. I have him right there, but I think David has that too. So sometimes it just goes like this. Oh, maybe not. Okay. Yeah, David was actually preparing stuff for today's program, but I thought maybe we could pull that up. Well, if you get it, that's fine. You can get it. There we go. Yes, that's my favorite animal. And sometimes it feels, yes, sometimes, thank you. Sometimes it actually feels like that to me. I don't know what it's like for y'all out there, but that's how it feels to me. So I want to give you a quick tour of what it is we've done. Now, this is the base. You see our broadcast desk. You see our new monitors back there, which is now sort of a video wall type of setup where we're going to be able to do, let's say, operating room scenes and stream them into there so that you can actually see something going on in the operating room. It might be even me doing it. Maybe it's an angiovac case. Maybe it's an ECMO. Maybe it's a heart, whatever the case may be. You'll be able to see it, but it'll also be streaming on the desk here. We may have people at the same time who can commentate about what they're seeing up at the monitor and what you're seeing there at home or the office or wherever it is you may be. Okay, so this is our standard studio. You've seen it many times. It's what it looks like, and I'm very proud of it. I think it's turned out super well. But let's take a look at the simulation section. So I'm going to wander over there. So we're going to camera 2? Okay. So this is our simulation section. This is obviously our ECMO platform. We're using the LivaNova SCPC, which is kind of a System 3 base. Now, they have discontinued this particular model, but I still like the platform. The other platform that they have with the S5 is a little too big and bulky, but that's another thing altogether. We could talk about ECMO platforms all day long, but there's so much that needs to change with this to make it so that, because this is very affordable. And the other things that are out there are very expensive and almost to the point of being cost prohibitive. It's really difficult for somebody like me to take a system like this that is so highly functional. I can transport it on an airplane with this. I can transport it on a helicopter with this, because you don't take the whole trolley. You just take the battery pack, the controller, this pump, the hand crank, obviously. It all fits on top of the patient with a little base that we have, and it goes on the gurney and just goes with the patient, and you can control it from the side. So very nice platform, and unfortunately, though, there's not enough money in it, so they've discontinued this, which is disappointing. We're also using in this scenarios, we're using this is a polypropylene fiber oxygenator. You have, of course, polymethylpentene, but we can talk about that. Our centrifugal pump is also LivaNova, our tubing. This is our mannequin here. You can see up at the top we have a reservoir that we use to flow back and forth through. The lines are going into the patient here and here, and then coming out the back and making their way there. This patient, if we go to camera 5, just a down view for a second, you can see the patient here. We have everything happening with that, and then we'll go back to camera 2. I apologize. And because I don't think you can see it underneath the bed. So I don't think you're going to be able to see it without the Mevo camera, but maybe you can. Right here is the ECMO simulator. It's right here. It's silver. It says CLR on it, which is Curtis Life Resources. You can see it, and you can see it on the bottom. Very good. And that's our ECMO simulator from Curtis Life Resources. It's the Eigenflow. And then we go to, where do we go now? So back to 2, and then you can see here we have we can have a urimeter. This patient was obviously given methylene blue. We have the transonic elsimeter and that kind of thing. So let's go to camera 5 and let's do all of those, whatever those zones are that we do. Let's just go through them all. So this is an overhead view of the patient. The patient is actually cannulated in the abdomen here, and the lines are going in. So we make all of our connections in here. So I'm going to go ahead and cover that back up again. You can see that we have, so we can go to zone 1. Let's just go zone 1, zone 2, just go through all the zones. So we can look at the cannula here. If we're looking at the chest, we can look at the cannulation coming out of the chest here. If we're looking at the groin, we can see it here and check our cannulation site and so forth like this. And let me go like that. There you go. So we could check and see what, oh, where'd we go? After zone 3, we go to zone, well, I wanted to also show that you could see the legs, and if you had, yeah, there you go. And if you had any kind of bluing or modeling or whatever, let's say you were cannulated in the femoral artery instead, we could mimic that here with just some coloration, and it's simulation, so you have to take that into consideration, right? But you could see it, and then the appropriate thing would be to put an SFA line in. And then we can go to the next section. So here's our ECMO pump itself. You can see everything very clearly. You have, and I had put some red dye in this, but it really didn't work that well. I didn't like it. I don't think you need it. But here is our centrifugal pump. You can see our access line to the oxygenator, line coming out of the oxygenator, various different recirc lines, our oxygen line hooked up to an oxygen tank back here, our pressure monitors here, transducers, and we have all of that. And then what's next? How about camera? No, let's do camera 6. So let's look at camera 6. And this is another view of the same thing. So if I want to shoot a recirculation, you can see the transonic elsimeter simultaneously to seeing the circuit and understanding what direction all of these lines are going. Coming from the field, red, and which is going blue, I'm sorry, coming from the field, coming into the pump, out through the oxygenator, returning to the field as arterialized red blood. And the tubings are all marked, and I put tape in various different locations so that you could understand very easily what is supposed to be blue, what is supposed to be red, and then you can see this monitor here, which is the transonic elsimeter. And we can focus on this and simultaneously so you can see the injection and understand it. Oops. Yep. That was I didn't move the camera. Magic moved the camera. There you go. We could see the injection and understand where it's going and how it's actually done. And then once this begins to analyze, we can focus in on this as well. There you go. That's perfect. That's really good. That's going to look really good. You can also see some cannulation issues here if we had bleeding or whatever the case may be. So I think this has turned out pretty well as far as having, actually really well, I'll rephrase that, with everything we have. Okay, so now let's do a quick tour of the entire studio. So I'm going to walk from here to this side, and you can see the back of the studio. There's David and Magic. You guys can wave. There you go. And then we can just pan all the way around. And we can come over to what is our green screen. Now, our green screen area, as you can see, the wall is painted green. You see our podium here. And on the podium here and here are my slides for any kind of slide presentations. What camera am I looking at? Mevo. Mevo or 6 over there? Okay. No, that's okay. Stay right there. And we have a ventilator, we have a patient monitor, an instructor and a student or learner. We have the eigenflow iPod, which has the app on it that I can change various parameters with. Amazing studio. Thank you, Hassan. So we have that there. That is really cool. And now here's for the magic, okay? So the magic part of this I just love. So we're going to go, here we go. There it is right there. So we have, and then I think David usually puts me in there too. But he's getting there. And so he has to, there's a lot of buttons that you have to press to do this. And it's only two, and really it's two guys back there, but mostly it's David. Oh, it's not working? Oh, okay. Yeah, it's blinking green. Well, let's go to another camera and I can talk while you do that. So, yeah, camera one, that's good. So getting back to the eigenflow also comes with, so let me grab the iPod real quick because I can talk about this. I just have to unplug it. So just give me 1 second. So Paul Curtis, nice guy, great guy. This is where I got it from. So on the iPod, it has a variety of different things, and you're going to see that as we go forward. But you have selected scenarios that you can do, which is oxygenator failure, venous air entrapment, high pre-oxygen pressure, high post-oxygenator pressure, VV ECMO preparation, leaky stopcock, ECMO pump chatter, which I'll show you today, kink tubing, hypovolemia, cardiac tamponade, and differential hypoxemia. And it comes with a monitor that integrates into this, and all of these parameters you can change on your screen here. It also has a book, which I think is very useful as well. And in the book, they have, which this is the book here, I think you can see it, Eigenflow Advanced. And you have a variety of different things. And I'm just going to get right to the section. So there are clinical scenarios that you can do, and I think you can see that, which has the yellow is for children or orange, and the blue is for adult. And you have oxygenator clot. It tells you the information, gives you the scenario, everything you need to do. And so amazing. Thank you, Sumithi. Here's at the pediatric one here, air entrapment. That's a problem regardless, right? High post-oxygenator pressure, high pre-oxygenator pressure, and you just go on down the list. VV ECMO preparation, so there's a lot of things you can do. Okay, we've got it going now. So I'll go back over there. So Curtis Life Resources, check them out. Eigenflow. I'm very pleased with it. Okay, so this is where the magic happens. All right, I'm back. There it is. So now we're able to bring you everything that you see here. So I'll start from the far side, which is on your left, top left, is the patient monitor. And in the patient monitor you have, and this comes from True Monitor, it says it right there, your heart rate, you can change the EKG to something else, atrial fib, VTAC, whatever you want to do. You have your blood pressure, your invasive, obviously. You have your pulse ox, you have end-tidal CO2. Down here, you can run a non-invasive if you want to check and see what's going on. You have a patient temperature. There are a couple of other things that you can put on here that are variables that you can look at, like PA pressure or CVP or LA pressure or whatever you want to do, right? Then here's our ventilator. This patient has moderate to severe ARDS. They've put the patient on APRV as a setting so that they can extend his eye time, and this is going to be what we're going to have for the first scenario. You can see our peak pressures are 20, And that's where we've limited it. He's got reasonable tidal volumes, 399. I've seen them as low as 50 cc's, so not too terribly bad, but certainly low. This patient does have a compliance problem, but we are on lung rest settings with the lower pressure, which could be actually lower, and then also the FiO2 down here that you see right there is 40. And all of these parameters can be changed while we're doing the various scenarios. Here's our ECMO controller, the SCPC. This dial here increases and decreases your RPMs. Here you have the various pressures, the return pressure, which is positive, your access pressure, which will be negative, and understanding these relationships as they relate to the flow, obstructions, cannula size, all of that kind of stuff. This is our eigenflow monitor. You can have a bunch of information on this and have that be much, much larger. But what we have on here is sweep and FiO2 of the ECMO for the purposes of the scenarios that we're doing today. There'll be other days where we do scenarios where we'll be using this more so than we'll be using these. But those will be different scenarios that we're going to do. And then here you see our camera angles that we can do. We can change this on the fly. So let's go to camera 5, down looking view. Camera 5, zone 1. And we have a little map, and I've tried to remember as much as I can, but I haven't remembered a whole lot. And then David will move that camera 5, zone 1. There you go. Camera 5, zone 1. So if we wanted to talk about the cannulation site in the right IJ, let's say this was a dual lumen catheter like a Crescent or an Avalon, whatever it is, we would be able to look and see if there was some migration and how that may be affecting our flow, our pressures, and our patient monitor and our labs. Also, something else about the TrueVent, give you something very interesting that it can do, is I can come over here and I can do this. I'm sorry, hold on. Oh. I had to do that. Sorry, I had to push a button. I can come here, send and show. There you go. I can pull up patient labs. And let's look at that, okay? Now I just picked the first thing that popped up, so this is not necessarily related to our simulation today. But I can do that. I can also come over here and I can do an echo, depending on what it is I'm trying to show. I can also come over here and show a CT. And we could look at, those are some really crappy looking lungs. We've seen that many times. We can show various different images, including some good x-rays. So here is a very good x-ray of COVID-19. And you can see this is somewhat asymmetrical. The right lung's a little worse than the left lung, but you see that haziness, ground glass, opacities they talk about. I've never really been able to appreciate it. But so there's a host of various things that we can do while we're looking at everything else that's going on and put them all into context with one another. And that's what I really like. We can blow up SimMan and look at that in a large screen. We can make him full screen. And we're learning. So sometimes it takes just a second for us to get all of our ducks in a row. And David is one person doing the job of 10. There we go. So we can make that large and be able to talk about that. And what's so really cool about this is, if you don't mind, just leave that there for a second. I want to show people something, because I can walk all the way over here, and I can take this and I can point to something from over here on that monitor at the same time I am touching the patient to bring your attention to it. I think that is just so incredibly cool that I can do that. Okay, and then of course we can do our slides. So once we get through with that, and this is going to be our scenario today. And so I've given you a tour. You've had the grand tour of the studio. I have to make a few minor adjustments in order to be able to begin this scenario. So we're going to take 2 minutes. 2 minutes is long enough, David? 2 minutes. We're going to take 2 minutes and get everything set up, and then jump right back into it. And we'll start with scenario number, the first scenario for today, which is actually going to be titled Hyperdynamic Patient VQ Mismatch of the ECMO Circuit, which is going to be, I think it's if we understand what VQ mismatch is, I think you're going to see that you can have a VQ mismatch of the ECMO as well. I think it's an entertaining but very informative simulation. So 2 minutes, please. Okay, and welcome back. And so we're going to go ahead and get started on this scenario, which again is VV ECMO. Well, no, go back to that. I just want to stay on the slides. Hyperdynamic state and VQ mismatch of the ECMO circuit. So we're going to go here, and we're going to click this, and we're going to begin the scenario. Now, I want to set this up so we have sound and everything, right? Okay. So you come in, and you're taking your shift over, and this is what you find. You going to go to the multi-pack? Yeah, multi-screen. Okay, here's how you start your shift. And I don't want to say what you actually say, but you're going to say probably something similar to what I'm going to say. You have to be kidding me. And it gets reported to you that this has basically been going on all day. The patient is tachycardic. Patient is mildly hypertensive. Saturations are not good. And the ventilatory settings, as you see, are what they are, and no one has done anything yet to try to address this problem. Patient's temperature is 36.4, so they're certainly not febrile. Our flows are 3 liters. You got plenty of room to go. Our pressures, access and return, are relatively low, and our FiO2 on the oxygenator is 100%. So I'm going to put this on pause, and we're going to take a look at some things. So let's go large on the monitor. So the patient is COVID ARDS, 44-year-old female, 170 centimeters, 60 kilos, BSA is 1.7. This is ECMO day 10 with dual cannulation technique, not a dual lumen catheter, dual cannulation technique, which is a 22 French access catheter in the right femoral vein, which is inserted up into the low or to the high inferior vena cava at the IVC RA junction, and in the right IJ is an 18 French percutaneous arterial catheter for the return, and that is positioned in the SVC, somewhere close to the SVC RA junction. The patient's vent is at lung protective vent settings. I showed you that a little bit earlier. Our current ECMO settings are a blood flow of 3 liters per minute. FiO2 is at 100%. Our sweep is at 4 liters. Temp is 37.2 or 36.4, whichever you want to believe, the monitor or me. The patient is very hypertensive, or had been very hypertensive, and this is given to you in report, and tachycardic for several hours now, and the patient was given 2 rounds of 20 milligrams of labetalol to try and control that, but it really hasn't worked all that well. So let's go back up to the monitor. And so you see again, here's our presentation. So let's go to a large view of SimMan, please. So initial camera 5. Perfect. I like the way that does that. So I'm going to walk over here to this. So a couple of things we're going to do is we're going to look at the patient, okay? That's number 1. What's his color look like? What's this look like? Is this return, this is the return, is it red? Because one of the first things you're going to want to know is your oxygenator, is this an oxygenator problem, or is this a patient-related problem? So is this red? We're going to look down here at the access. How dark is it? Is it coming out black? Is it coming out, you know, basically looking like, you know, on pump, you know, you got a little bit lower sat, and you can usually tell just by looking at the lines. In fact, if you look here, you see the lines together. Many times I like to put the two lines together and get, and can you come over here to zone 5? Yeah, that's good. And I like to put the two lines together and look, do I see a clear color difference? And if I'm seeing that, and I have confidence just visually that the oxygenator is working and that's not the problem, we've looked at the vent, we've assessed that that's not the problem, well, then it's got to be something else. So let's go to my slides if I can, please. Excellent. So the patient SAT's persistently low, the patient tachycardic, hypertensive, and the condition since you started your shift is deteriorating. So you've just been handed a real gem, if you will. So why is this happening? Well, check and confirm the vent FiO2. Severe ARDS, tidal volumes aren't that low, but there's a question as to whether you're going to get any lung contribution. So what do you know? But look, I mean, we're kind of in a mess here. So let's go to the vent on full screen if we can, and I'm going to change the FiO2 because that would be one of the first things I'd want to do. It's the easiest thing to do. And I'm just going to set that at 100% and continue, go to the multi-pack. And we're going to run this and see, do we get any improvement at all? Are the lungs going to be able to help me in any way whatsoever? And right now it looks like, well, I saw 81, and sometimes it takes a few minutes, but we may not see anything. So I would say in this particular circumstance, going up on the vent is not really helping us. And I think that at the end of the day, this patient is going to need something other than what it is we're able to provide here. But I'm going to leave it at 100% because it's the appropriate maneuver to do in this circumstance, right? And if you have an idea of something else to do, when I get through with this that you think I should have tried, please let me know. Because I'm trying to go through this just like I would as if, and I've done this. This is actually something that I have seen more times than I care to remember. The other thing we can do is we can check an ABG. So we're going to draw the ABG, and as you well know, when you draw an ABG, you have to send it out, and it's going to take you a little bit of time for it to come back. But let's see if all of these numbers are correct, because you can have a pulse ox that says that. Sometimes you can tell by the color of the blood. Sometimes you really can't. We're going to wait and see what actually happens. Now, I don't know if you noticed that or not, but this yellow button just popped up that says investigations right here. And when that happens, this is a very efficient lab. The labs will come back. And I'm going to pull it up. So let's go full screen on the labs. And sure enough, what do you see? Patient's pH isn't too bad. PCO2 is 48. PO2 is 57. Saturation is 83. So we definitely see a correlation. The labs, in fact, are real. So you have to now believe that pulse ox is accurate. Now we've got to come up with something else to do. So let us, if we may, go to our slides. And we ran the scenario. So let's talk about, actually, before I do that, go back to the multi-pack. So what is something else that I can do? Well, I can increase the flow of the pump, right? So let's do that. So magic, oh no, nobody's here. So excuse me 1 second, I'll turn the flow up. That would be the next maneuver. And I went ahead and pushed the flow up to 4.2 to see if that's going to provide us any benefit. And keep in mind that there are times when increasing your flow, depending on whether you have any recirculation, positioning of things, can actually make matters worse. And actually, I'm seeing that happen in real time. Our sats have dropped another couple of points, yet I increased my flow to 4.2 liters per minute. Now, it increased my access pressure to minus 87. My return is still relatively low. I probably still have room to go up, but increasing that flow based on the pulse ox, which I know is working because I checked it with the lab, got slightly worse. I don't know that I want to go up anymore. And we're going to talk a lot about recirculation and how that happens and why it happens and how going up on the flow doesn't necessarily get you out of trouble. It can actually make matters worse. So the other thing I want to do is I want to do a bedside echo of the patient. So let's order it. We're ordering a bedside echo. That is also a very efficient department, and they are coming in, and we have, in fact, the echo has arrived. We're going to pull it up, and there is your echo. We can go full screen, and you can see it's kind of jumpy, isn't it? Huh. Can't say I'm too happy with that, but because it doesn't look that way here. Well, that's a terrible image, but it's showing a very hyperdynamic heart. So I can't say I'm very happy with that, David. Is there anything we can do to make it better or not? I'd have to restart? Okay. So we'll just leave that alone. Okay. So we'll take that down. So we'll check that. The other thing that we can check is a flow track, right? Oh, let's see. They just put that up. I don't know why that happened. So I'm going to go to investigations. We're going to look here. We're going to look at a flow track. The flow track shows a cardiac index of 4.8 liters per minutes per meter squared, which is enormous. That's a very high cardiac index. So I'm starting to develop a train of thought here that I think might make sense. And it may make sense to everyone. There's one other thing that I want to do, and that is I want to check a recirculation. So we're just going to show a recirculation, and we will teach you how to do it properly. But right now, I just want to look at it and see what it says. And we do a recirculation with the transonic ELSA meter, and it is less than 5%. Any time, and these waveforms are very simple to interpret. Your initial injection is going to give you an oxygenator blood volume. That's this curve you see here. The red curve is the first pass past the electromagnetic transducer, and this is what it sees the density change. And then the blue is the blood coming back to the system, which is going to measure recirculation. And then after that, it goes through the capillaries and it keeps coming back and trails off. And it internally calculates the recirculation, in this case, less than 5%. It also calculates oxygenator blood volume, and in this case, it is 99% of what was the baseline when you first set it up. And it gives you your arterial flow and your effective ECMO flow, which is this number. You can see they're both the same, okay? Anytime you see a very, very low, less than 5% or absolute zero recirculation, and you'll hear me say this many times today, it is going to be a result of a hyperdynamic state. In other words, you're only flowing 3,700. The heart is probably pumping 8, 9, 10 liters. So there is literally so much flow that even with a slightly malpositioned cannula or not the best cannulation strategy, the washout is so fast nothing is coming back in recirculation. In contrast to that, if you see a very high recirculation with perfect cannula positioning, it is almost always due to at least right heart failure or some kind of heart failure, because there's so much time you're flowing higher than the cardiac output and you're getting that volume to come back. And we can discuss that when we train. We do an actual simulation on the transonic altimeter, and we shoot it, and I can show you how all of that works, and it will make sense to you a lot more. But this, I think this is very easy to understand. The oxygenator blood volume is very important, because if this is VV ECMO, but even if you were VA ECMO, you can run the oxygenator blood volume, obviously not recirculation. But this tells you the health of your oxygenator. The only thing that will reduce that is going to be clot. Not going to be styrofoam, because that's not in there. It's going to be clot. So if you're running very low to no anticoagulation, which we have done a lot of, this is something you're going to want to measure at least once a day, probably twice a day, to make sure that the health of your oxygenator is okay. You don't have an impending problem. You can lose up to 50% of your oxygenator volume and not see a significant increase in your return pressure. So your pre-oxygenator, your delta P across the membrane, whichever you prefer to measure. There's all kinds of places to measure, and we'll discuss that as well as we get through these simulations. So let's go ahead back to the multi-pack if we can. And we've looked at all of that. We can go back to the patient monitor and take our, oh no, I have to do that, not you. Thank you. Okay, so now what is another option that we can do? And let's go back to our slides. Well, we can keep trying to increase flow. We can add cannulas. Access is probably your limiter more so than return. But, you know, you'd have to make that call. You can do dual circuits in the butterfly technique, and I'll show you what that looks like. You could lower the patient's temperature a little bit just to deal with the low cardiac, with the low saturation, at least temporarily. You don't want to leave it there for a long time. Maybe some increase in infection risk and things like that. Or you could give a short-acting beta blocker like esmolol. So let's see. Here is basically, this is the cannulation technique we're currently using. We're draining out of the, you see it here in the high IVC, coming down this way, going to the pump over there, and it's going through, and returning back to the heart, and you can see it there in the low SVC at the RA. This is the technique that we are actually using. And what you can do if you want to is, as you see, this is just a diagram hand drawn. Oh, I just froze. Hold on. I don't know if y'all can still hear me, but just go to a different camera, dude. Do something. Go to camera 1 while you fix it. There you go. I'll come over here so that they don't just look at that. Technical difficulties. That's what you gotta love about doing these kinds of programs, is technical difficulties. They're always fun. And so we're turning it off and turning it back on. But getting back to that situation that I was talking about, you know, you can add cannulas, and we're going to talk a little bit about that and why you have one is better, access versus return is better. So we're going to, I think we're ready? Not yet. Okay. And while we're talking, let's see what else I could talk about. The next simulations that we're going to do, we're going to have, I think Ann Gretcho is going to be joining us this afternoon too. Okay, I got the thumbs up. We're ready to go. Okay, I was running out of mumblings to do. I wasn't doing too good extemporaneously that time. So let's throw our slide back up. And almost always, when you have a problem with flow, a limitation of flow, it's almost always going to be access. It's pretty rare that it's going to be return, unless you've got a really small cannula in there, big access and a small little return. But you can usually pump through something a lot easier. You can suck it out. A hard cardiac output and mismatch ECMO blood flow. Bingo. You know what? Your Simothy, excellent. Okay. So what we're going to do is add another access cannula here and wire them together right here, going to the centrifugal pump itself. So in this way, you can increase your access if you had high negative pressure and make that a little better. But that's really not what we need to do in this circumstance. Actually, and let's talk about the Simothy gave us the answer. So, and let's see if anybody else can get the answer. I'm curious. So basically, here's the parallel circuits for patients that need 10 liters of flow. And you're taking from the right femoral going up to the right IJ, the left femoral with a totally different circuit going up to the left subclavian. And in this way, you basically can increase your flow to astronomical levels. And there are some people that may need that, but I can assure you there's going to be a lot of recirculation going on in this, but you have to have it. There are some patients that just need that. Okay, and let's take those. Let's go to the, yeah, that's good. I also wanted to talk about what is wrong with this patient. How are we going to fix this patient? Well, I'll tell you what I would do, and Simothy has done the exact same thing. I'm going to start some esmolol. So the nurses have got the esmolol. It's on the thing. It's running in. It's so rapid and so short acting. You can always turn it off, and immediately you see significant improvement. In fact, so much so that I can go back and turn my inspired oxygen on my ventilator back to 40% so that we don't cause that caustic damage to the alveolus from the high inspired FiO2. And look what's happened. Our heart rate's dropped. Our blood pressure certainly has dropped as well. If you're hypotensive already, esmolol can be a little bit tricky. You got to be careful. But this patient is young. That blood pressure certainly is fine for them. Look at our SATs bumped right back up again. And this has all happened because of, and let's go to the slides, at a full slide. This has all happened because of VQ mismatch. We're going to talk about how, one, VQ mismatch of the lung. We all are very familiar with this, so let's just go over it very quickly. You can have hypoventilation. You can have intrapulmonary shunt, like a PE or something like that. You can have a ventilation perfusion mismatch, which is a low VQ. And you can have what we're dealing with in this scenario is a diffusion impairment. And if you look here, you see the representation of these alveoli are showing a thickening. Okay, you don't see it in the other ones. So this is what we're dealing with. High airway pressures, very non-compliant lungs, thickened diffusion barrier, your alveolar capillary membrane, and this is going to cause you to have a very low PO2 for that patient. So if the patients, and here's another representation, I think this is even better actually, that's basic VQ mismatch. So VQ mismatch of the ECMO circuit is this. Your cardiac output of the patient is 6 liters, possibly even higher. Your ECMO flow rate is only 3 liters. You're assuming, for the sake of this discussion, 0 recirculation. That's going to give you an effective ECMO flow of only 50%, which means, in essence, only 1.5 liters of that 3 liters that you see there is actually making its way to the left atrium through the pulmonary veins. So you have 3 liters of blood coming down this way, and I'm just splitting it. It's probably not exactly that, right? And we have 3 liters of blood coming from the bottom portion of the body. So 6 liters is dumping into this area that's desaturated, deoxygenated blood, venous blood. The ECMO is only pulling 3 liters of it. So 3 liters never gets into the ECMO cannula and makes its way to the RV, the pulmonary artery, through the lungs, where it's not getting any contribution coming back to the left atrium. So now you have basically split. You can have a PO2 of 300 coming out of the oxygenator. It's still only 100% saturated, right? The PO2 is a minuscule amount of actual oxygen. It's all in the saturation. And you're saturated at 100% here, but you're mixing it with a saturation of only 70 or 80%. It's going to be much, much, much lower, actually lower than that. You're saturating it at 60%. And so you can see why your arterial saturation is going to be low. That is a classic VQ mismatch of the ECMO circuit, which is exactly what Sumathy said. So my compliments to Sumathy. In fact, we're going to send you either, I think, one of the wine goblets or a coffee cup. The wine goblet can be used as for a cold drink or a hot drink, whatever you want. So there's some options there, or a t-shirt, cap, whatever the case may be. Okay, let me see if I have any other slides if I can. Go back to the multi-pack. And I think we have one more simulation to look at. Yep, that's, I think, the last slide. I think we looked at this. Did we look at this slide? No, I don't think we did. This is another very good slide. I think it explains it well. You can see your access here. You can see your access down here. And you can see your return here. If what's in this gray line is 3 liters combined, 1.5 from there, 1.5 from here, but what's in here and here combined as it enters here is double that, then you're only treating 50% of the blood that's coming out here and going into the RV. So you're mixed down here, and that's what I was referring to as far as that's concerned. Okay, so let's look at one more thing, and that's the patient monitor. And we've repeated the blood gas. And let's see. Forgive me. Oh. There you go. Oh. There we go. There's the blood gas, okay. So let's throw that up and make it large. And look at this. Our PO2 is 89.7. Our PCO2 looks great. pH is good. SAT is now 97. And everything else looks good. So you know what this means at the end of the day? It means you're going to have a great rest of your shift. So we can go back to our movie, or we could go back to our game, or we could actually help the nurses with turning the patient, cleaning the patient, checking the patient, checking our circuit, which we should always be doing very diligently. But at least you're not going to have that issue to worry about. So we're going to take a 5-minute break while we get prepared for our next simulation, and we will be right back. Welcome back, and we're going to start with our next scenario. Let's put our slides up if we can. And what I'm going to do this time is I'm going to go through the slides a little bit farther and then start the actual scenario. So this is a recirculation of the VV ECMO. So patients on VV ECMO, in this particular case, please forgive me, it's going to be a double lumen single cannula technique coming from the right IJ. And we're going to look at the patient. Patient is COVID with severe ARDS, 50-year-old male, stable, currently in prone position. Patient is 180 centimeters, 90 kilograms. BSA is 2.1 meters squared. This is ECMO day 34. We have the patient on lung protective vent settings, but you'll see here shortly that's not, his lungs are very stiff. Current ECMO settings are a blood flow of 4. Magic, can you help me out? Make sure it's 4. 4, and the FiO2 is 100%, and the sweep is going to be 7 liters. There you go. All right, so let's see what's next. The event that's going to take place is we're going to turn the patient from prone to supine, because obviously we do that right on a timing basis. Immediately upon turning prone, the patient's pulse ox is going to drop. Patient's going to become unstable. ECMO flow will remain unchanged, and we will send some labs. So our investigations are going to be, well, check the ECMO flow. What's the SaO2 in the ECMO circuit? Is this a hyperdynamic presentation? What's the SVO2 of the ECMO circuit? And then we're going to notice some red flashing, and we're actually going to run a recirculation with the transonic ELSA-meter, because I want you to see how that works. Additional examinations we're going to do are X-ray, and now we're ready to actually run the scenario. Okay, so we'll stop there, and let's go back to the full monitor, the full pack, if you will, please. So we've flipped the patient, and think about it, unless you're using a rotoprone bed, and go ahead over to, let's turn the patient. So think about this for a second, if you would. Here's our cannula, our dual lumen catheter cannula here. We're just simulating it. But you're going to take this patient from being prone, and we're going to flip that patient to being supine. And one of the things you want to look at, looking at zone 1, is you always want to make sure this is staying stable, and you want to have something, a picture that is available to everyone where this cannula is in the body or at the level of the neck. Now that is not 100%, and we can talk about that a little bit more, but let's go back and let's check on this patient again and see what's going on. So let's look and see what's going to happen with this patient. They were going along, so far good, and we have now turned the patient, and let's see what's going to happen. There we go. Okay, now we're moving along. So turning the patient, and you can see our flow is 4 liters. Our return pressure is 56. Access pressure 79. We're at 7 liters of sweep with 100% on the FiO2. And we start seeing now a little bit of a change. We're starting to see the saturation drop a little bit. We have turned this patient, again, something has happened. We have made a major change. You can see that the ventilator, go pop up full on the ventilator if you can. I mean, look at this patient's tidal volumes are 102, peak pressures are 30, 40% on the FiO2. Of course, We can always go up on that. So go back to the multi. But we can see here we're starting to get some alarms. Our sats dropped to 86. You see our pressure still doing okay. Our temp is 36.1. But clearly something has happened. I haven't seen a change here, and I haven't seen a change here. But, you know, what could potentially be going wrong here? So one of the things we're going to want to do is, of course, we're going to send a blood gas. But let's go through the various things that you're going to want to do just normally. And I want to stress this because I think it's very important. Something has happened. So we need to make sure that we look this over. So let's go over here and let's do that down view of the patient again. Now, what we would normally see, which it's going to be very difficult for me to show you this representatively, but I'm going to do my best to try it because we don't have a, it's very difficult to put these cannulas in and have it be the Avalon and so forth. But you know your access and return lines would be up here, as you see in this configuration. And you would see a color differential here. And in this particular case, what camera are we looking at? Yeah, that's perfect. You would definitely see blue, red, dark, bright. And then you look at the position. Is it anything obvious? Has it, in fact, you know what? Let me do this. I'll put this back over here for now. And I'll show you with this catheter here, because these are the various things that can happen. This is what it would actually look like. And if it was like this on yesterday, but now it's like this, or it's like this, or it's like this, and you've marked, you have a representation, an image of what this, where this was yesterday or before you turned them, because this can get moved very easily. That's why I think the subclavian approach is sometimes liked. We can talk about that during another scenario, but for right now, you would want to look for rotation. So this is what you would want to check. So I'm just going to set this right here for now, and I'm going to put this back where it was. If you let me indulge me for just a second to sort of re-tidy up my area. I'm going to put this back so we can do the scenario. And what you notice is, and there's various different tubing holders and things like that that you can use. And I'm going to put that and then take my towel and put this here. This is where we're measuring the positive pressure from, or the return pressure on that. But yeah, back to this again, you're going to want to check that. So that's what we're going to check. We're going to look at the patient and see if anything else obvious has occurred. But you know what? We don't really see anything. It looks like maybe the cannula moved. And I'm going to tell you, the cannula can move without it moving at the level of the skin at all. I've seen people's bodies change enough internally that the cannula just has ended up in a different spot. Something that you really have to take into consideration. So we sent that blood gas off, and we're just now waiting for the results. That should be coming across momentarily. And in fact, it has. So we're going to take a look and see. And sure enough, the labs look as you would expect them to. Your PCO2 is 65, pH is 7.29, PO2 is 58. This patient has been metabolically alkalotic because of chronic hypercarbia. So they still have that compensatory thing going on, but that PO2 of 58 and saturation of 79 is not going to be something we're going to want to live with for a very long time. So the question is, what do we do? What else can we check? Well, we talked about this, the SaO2 in the ECMO circuit. So I can run a circuit gas, but I looked at it. You know, running circuit gases, I think, are great if you're really trying to trend the device. But as a perfusionist or as an ECMO specialist or as a nurse at the bedside, if you can't look at a line and tell whether or not it's arterial, it's red, or it's not, or, you know, obviously, then you need to look at them more frequently. So let's see. We have another. We decided we were going to look the patient over again, and this is something that somebody noticed. They were looking at the patient, and they found this. So take a look at this, and I'm going to loop this. Okay, I want you to look. This is the return. This is the access. And if you watch, you're going to see red flashing. You see it right there pulsing? It's red. This video is also kind of jerky. It should be much smoother than that. But there is red flashing in the line. That is generally an indication that there is very high recirculation. This should be red. You can definitely see a color difference. The red line, the return, and there's your access pressure, or your access line. And if you look at it carefully, you can see that red flashing. You see it right in this area. And just keep an eye. Can you make that big? And just watch, and you'll see it. There it is. There it is. Very good. Okay. Excellent. Thank you very much. Okay, the next thing we're going to want to do is we're going to want to run a recirculation. So I was going to do it right now, but you think I should do it on the next one or do it now? Why don't we just go ahead and do it now? So I'm going to teach you guys how to run a recirculation and why it has the value that it has. So let's go over to SimMan, and I'm going to run a recirculation for you. So how this works, and what camera we're going to use? I don't know. Go to camera 2. So how this works is you have a box. I'm going to show you a close-up of all of this here in just a second with a different camera angle. But it has 2 probes attached associated with it. The first probe is going to go on your arterial line as it exits your oxygenator. Say that again? No. As it leaves the oxygenator. And it's just before your flow probe. Doesn't matter which side these are on. This is the flow probe to the pump. This is the flow probe to the ELSA-meter. And then it has a flow probe on the venous line, and I usually put it up close to where the access port is. So in a VV ECMO situation, the access line would be up here towards the neck, and the return or the red down at the arterial line there, okay? So what you need is normally saline because it has a different density, and we're going to go to camera 6, and we're going to look down at the ELSA-meter and the pump combined. That's perfect. That's a great spot. And I can find a patient, but I'm going to create a new patient. See, I didn't want to do that. Select patient. Oh, I did the wrong thing. Z. No, I don't want to do that. Add patient. There we go. Add a new patient. So last name is going to be Man. First name is going to be Sim. Okay, and his medical record number is going to be Tom 123. Hit OK. And now we're loading. And there he is. And we're going to measure the patient. Now, we're VV ECMO. So we're going to click VV ECMO. It's very simple to do. You can choose to measure monitor flows, recirculation test only, or recirculation and oxygenator blood volume. It makes no sense to me to not do both and not just recirculation. If you were VA ECMO, you can only do oxygenated blood volume. You can't. There is no recirculation, but you're going to pick this. Recirculation alone doesn't make any sense. You can also monitor flows. So you can monitor 2 flows if you want. But right now it's doing, let's just do this. So place the arterial flow sensor on outflow line close to oxygenator. We did that. Place the venous flow sensor close to the patient. We did that. Click OK. Now, it's asking me a question. It wants to know how much volume, and can you focus in on here? To the right slightly. That's perfect. How much volume, so this is the outlet of my centrifugal cone that you see here, going down. Here's a port, and here's the inlet of the oxygenator. It wants to know how much volume there is between here and here. So I'm going to put 20 cc's. That's what it is about, 20 cc's. Click OK. And that's going to help with the measuring of the oxygenator blood volume. It needs to know that. It says when the countdown is finished, to make injection, press Ready to Measure button, and then inject 1 milliliter per kilo or greater than 5 mLs up to 20 mLs of isotonic saline after pump and before or into oxygenator, which is what we're doing. And we have 40 seconds to go. So I'm going to come down here into my cup that has a solution of a little bit of glycerin. So let's go to camera 2 while it's doing the countdown. There you go. And the cup has just a touch of glycerin, which changes the density of the water, which is what's flowing in the patient, because that's what it's doing. When you use isotonic saline, it's safe to give to the patient, obviously, but it's going to have a different density than is the blood. And what's important about that is that the sensors look for velocity changes, and you need a different density in order for it to be able to pick up on that, is the reason for that. Okay, so let's see what we're saying here. So it's ready to go. So let's go to this. There you go. All right, and you're still going to need the other because I have to inject, so we're going to do both. But they were able to see it. You click Ready to Measure, and now at this point in time, you have a green light here, and there is no rush. You don't have to rush through this, so there's not a time. It's only when you inject and it senses it. And that looks good. So let's see how much our recirculation actually is on this patient. The key to the injection is, and I have a dead end port here, is it needs to be rapid. You don't use 2 hands and plunge, but it needs to be swift. You have to make sure you turn off all recirculation points that you may have. So I've discontinued that. And you get yourself prepared. I usually start applying pressure, slowly turn the stopcock, and you'll see it go in. That fast. That's how you do it. Now you come over here, and it will sense it, and you will see it go into analyzing. And you can sometimes do multiple injections, let's say 3 of them just to validate, or 2 if you get 2 exact numbers, especially when it's a number you don't like or you don't want or whatever the case may be. But it's doing, you can see some waveforms here as it continues to measure and see what's going on. You don't have ELSA monitor. We do venous gasometry, yes, or the SVO2. We can discuss that. That's very, very true. And in fact, I'm glad you brought that up. And our research, and we're going to use this as our oxygenator blood volume, yes. And look at that, our recirculation is 72%. So we're flowing 4.2 liters per minute, and our effective ECMO flow is only 1,200. And you wonder why the patient isn't doing well. Okay, so let's go back over here. And I want to address that issue of the using the SVO2 as a surrogate. That is so very, very true. Oh, am I there? Hello? Oh, can you go to a different camera? Okay. So, yeah, 2 is fine. I mean, that's fine, whatever. So let's address the issue of using the SVO2 as a surrogate. So you could take a sample from here or a sample from the line itself. It doesn't matter. The blood before the pump is the same blood as after the pump. So if I drew an SVO2 here and had a baseline and it increased significantly, of course, with the 72 recirculation, it's going to increase significantly. That would be a surrogate. Now, it won't get you an absolute number, but it definitely would tell you you have a lot of recirculation going on. But keep in mind, you can also have a drop-off in consumption. Your metabolic demand, for some reason, has decreased significantly. You're not extracting. There's a whole host of reasons that you can have a bump up in your SVO2. Now, at 70% recirculation, I agree, it's going to be very high, pretty close to arterial in this particular case. But for the purposes of this, let's say it was 50% or 40%, it's going to be very, very, very difficult in order to figure that out. So, yes, it does work if you don't have the ELSA meter from Transonic. I don't make any money from Transonic. They don't pay me to do anything. In fact, it seems like I pay them for anything that I do. They did give me a backpack once, if that counts. I would get this. This device has so much utility, and it's so inexpensive. You can take it from patient to patient. I really believe in this device. And so, I mean, it's a $20,000, maybe $25,000 device, and you can use it on multiple patients. I think it's much better than using SVO2 as a surrogate, but I agree with you 100%. If you have nothing else, yes, that is a way to do it. And in this particular circumstance, I further agree with you that you would see pretty close to arterialized blood in this line as opposed to venous blood. If it was more subtle than that, you might not actually be able to detect that, because there will be fluctuations in SVO2 depending on cardiac output, depending on SaO2, depending on extraction rate, just a whole variety of different things. Temperature can affect your SVO2, so keep that in mind. So let's try to figure out what actually happened. So I'm going to continue this, and I think we have a couple of other investigations that we can do. So let's see. We looked at the blood gas already. We looked at that. We did the recirc, which ours was even higher than this at 65%. And I think we have some more investigations which are going to be coming through. I'll just speed it up if you don't mind. And we'll take a look and see if we got it yet. Nope, not yet. Oh, I'm clicking the wrong thing. That's the problem. It would help if I clicked the right thing. Okay, let's go large on the x-ray, please. And where's my light? Because I think that might work. This might work. So what you're seeing is Here is the catheter coming in, going down, and it should be going this way. But look at where it's going. It's going this way. And the catheter, the Avalon catheter, is actually in the right ventricle. So is there a way to can you brighten that up at all? You can't? You can't make that brighter? Okay, so I don't know if this will show up. You know what I want to do? Let me do this. Give me just a second, and I think I might have the image. No, I don't have it on here, do I? I don't believe I do. No, I'd have to get it out of my phone and all of that. I don't know where it is. So, unfortunately, I can't pull that up, but it is right here, and it's in the RV, not in the IVC, which should be over here. So now you've got a big problem. The big problem is, how do you put that back where it belongs? Now, I'll tell you what we did, and then I'll tell you what I would do moving forward. What we did was we took the patient back to the operating room. We came off ECMO. We disconnected it. We pulled it back, put the dilator back in, put a wire in, and got it down into the IVC. We ended up having to change the whole catheter. We tried to do that first, took the whole thing out, just started over again with a new one, and got the patient back on ECMO. And the patient was really, really, really sick, and it was very dramatic. The patient coded. We did get them back. That patient ultimately, I don't believe, made it long term, but they did survive that event, but their lungs were just not recoverable, and they weren't a candidate for anything else. That COVID was horrible. This is actually the patient. This is the actual x-ray. So what I learned, though, is, let's go to our slides and go full screen on the slides. What I learned, and Tammy Sparacino did this on one of her journal clubs, was, and this is a pediatric case, but you could do it in an adult as well, and it's repositioning of a bicable dual-lumen ECMO cannula using a transfemoral lasso. I thought this was so incredibly, I wish I'd have thought of it. And it was published in the Journal of Pediatric Surgery case reports. And here is the initial cannulation of the patient, and you can see the white arrow is pointing to the level of the IVC. Here you see that same arrow pointing to the IVC, but you see the cannula is over here. So, in the tricuspid valves, probably somewhere in this area. So you're definitely in the RV. Here you see them pull it. They pulled the catheter back, and you can see here's the right atrium here. And you can see that they've brought a snare up, grabbed it, they pulled it back into the SVC. Now what they're going to do is pull it back down towards the femoral. It's going to go the right way. And here is the x-ray post repositioning, and you can see the white arrow pointing at the level of the diaphragm. And you can see that it's just infradiaphragmatic, which represents what you're looking for. That's the spot that you want the tip to be a centimeter or two below that point of the diaphragmatic bell. Okay, transition, access. I'm not sure what I'm doing here. So I think we've solved the problem. Let's go back to our patient monitor. We have safely repositioned the ECMO and the catheter, and here we go again. We're settled right back down again. This patient is looking better. Their heart rate is back down. Blood pressure looks good. Saturation looks good. Patient is doing well. You can see our ECMO flow. Everything is unchanged. The lungs are still not doing great. You can see the tidal volume there of 104. Certainly not good with a peak pressure of 30. So, you know, these patients that we did with COVID were very, very, very sick. They were very difficult to deal with. And in this particular case, again, that patient with the X-ray. I mean, we have our data. I'm still waiting for our data to be all tabulated, but it's discouraging at best for our COVID ECMO population. We had some saves, and they were wonderful, but our best saves have been PEs. We just recently had a patient. I have to tell you this case. Young lady, she was in her early 30s, late 30s, no, maybe late 30s. She had traveled abroad, I believe, to Australia, had come back home. She was, her mom picked her up, got her home, kind of got her settled in, and her mom was going to leave and go home. And she said, no, can you just stay with me tonight? And so the mom said, sure, I'll stay here tonight. The next morning, the mom got up and made breakfast, and they ate. And the daughter, she said, here, I'll clean up. So she stood up to get the dishes and took a couple of steps, grabbed her chest, and collapsed straight to the floor. And she was no pulse. Mom started CPR, called 911. Mom was not in medicine. The EMS responded. They did get a pulse back. They got her to the hospital. They took her to the cath lab, and they made every effort to try and clear the obstructions. She had a PE to get the clot out of the PA. They were able, they felt, to get her stable enough to just take her to the unit, took her to the unit. She lasted about 2 hours, had continued problems, was very metabolically acidotic. Right heart was really straining and dilating, and she was decompensating on significant numbers of amounts of pressors. Decision was made to put her on VA ECMO. 4 days later, we were able to decannulate her, and she did great and was able to go home. And those are the rewarding times, the rewarding cases. The COVID cases, we have dealt with those for months and have had them, a few, I would say 15%, that have gone on, maybe 10% to a normal life, 15% to some life, and maybe 10%. I'm not sure. Again, I'm guessing at these numbers, but they're probably not that far off. But that leaves a whole lot that didn't do well, short of a transplant. So it was a very difficult time for us, and hopefully we won't ever see that again. I don't know that I have it in me to do it again, but this was a real case. We actually did this. And as much of it was real as possible. Please give me your feedback on this, and then we're going to move forward. Of course, I'm going to take a short 5-minute break. I'm going to look at the clock, make sure that, because David said he's going to put a timer up, because apparently I don't keep track of time very well. But we're going to get the next scenario set up, and come back in 5 minutes, and we're going to get through that one, the third one, and then we're going to be taking a break for lunch, okay? 5 minutes. And welcome back, everyone, for our final morning episodes, scenarios, simulation, whatever we may want to call it. Is there there's no way to move that slide just a little to the left, is it? There's not much I can do about that, is there? I should have thought about that when I did it. Yeah, that's all right. That's okay. That's all right. It's oh yeah, that's good. I can move too. That'll work. That's perfect. Dude, you're so good. How do you do that? Okay. So this next scenario is going to be basically air in the venous line, but I'm going to make it a little bit more interesting than just that. I'm going to try and go over an ECMO circuit and what actually happens with it. So in this particular case, what you see is our drainage. Our patient would be up here, right? Our drainage is coming down, going into a pump, through a flow probe, which probably wouldn't be put there, through an oxygenator, back out now as arterialized blood, and back up and into the patient. And I'm going to show you over there with the ECMO circuit. Everything on this side, actually, let me just draw. Everything I don't think the pen's working. Okay. I mean, I had charged it, yeah. Everything that is on this side of the pump, this side, the patient side of the pump, is a negative pressure, -70 to -150, depending on how much flow, size of the cannula, all of that kind of stuff. Size of the tubing, how much of the cannula might be stuck on tissue. It's hard to say. But there's a whole variety of whether the tubing's kinked or not. Anything, however, on this side, the patient side of this centrifugal or blood pump of any sort, could be peristaltic for that matter, is negative. Anything on this side of the pump is going to be positive. Before the membrane is always going to be a little bit higher. That's your pre-oxygenator pressure, but it's positive. And then anything on this side of the oxygenator is also going to be positive, but generally a little lower. The difference between this pressure and this pressure is your delta P. So this going back up, arterialized blood, back into the patient. Now, why do I mention this? This is very important to understand. And I need to find a slide. And I think it's way down here. It is. It's right there. This slide is extremely important. Can you blow that up a little bit? Oh, I'm so sorry. Something's not working. Oh, it's up here. Like that? Okay. Thank you. This slide is very important, and this comes out of the ELSO book. And they're talking about who should monitor the ECMO. If you look over here, you have the categories: perfusionist, ECMO specialist, bedside nurse, and then cost of the circuit. This is manufacturer's list price, and it's a little dated on top of that. The Centromag, the perfusionist can watch it, the ECMO specialist can watch it, the bedside nurse can watch it. It's a $14,000 a piece device. And the Centromag doesn't have an oxygenator. That's just the cone and the circuitry that goes with it. The Rotaflow, on the other hand, which would be very similar to what we're using over there, only a perfusionist, cost $24.47. The Rotoflow ICU package, perfusionist or ECMO specialist, $24.47. And the cardio help can be perfusionist, ECMO specialist, bedside nurse, and the cost $13,781 per set. Now, I will talk about the cardio help just briefly. The cardio help is a great device. It's a good device. Good, easy for transport, very easily. It's very mobile. It's very small. It has a lot of advantages, but it has disadvantages too. Now, but the question is, and I'll need to stay on track here, why? Why is the Rotoflow only perfusionist? Why is Centramag all three? Why is the Rotoflow ICU package not include the bedside nurse? And why does the cardio help allow for all three? And we're going to talk about that here. But I wanted to show you that slide. Let me see. How do I, do you know how I, nope, I didn't want to do that. I'm going to, can you take my slides away, please? I don't, it doesn't matter to me what you do, just anything. Just take the slides away. Thank you. I don't know why it does that. I can't ever figure this out, Magic. Oh, there. I figured it out. It took me just a second. Okay. And let's see. Yeah, there I am. Okay, good. You can go back to my slides. Most excellent. Thank you. So, what's the reason for it? Oh, dude, this is killing me. Okay, what's the reason for it? The reason has to do with access ports. If you have any access ports, and it's one thing to have an access port here. It's, say you have a pre-membrane blood gas analyzer. You have an arterial access here. Okay, now this is the quadrox, so you can have one over here. I'm going to show you our circuits. You could have one here as well. In fact, let me use this. It's easier. You could have an access port here for drawing labs, depending on the type of oxygenator that you use, if it's cardio help or not, or the quadrox or not. You could have an access here. You can have access here. So there's all kinds of places that you can put access lines for a variety of reasons. But if you put access lines anywhere, you are increasing the complexity, because this whole simulation is about getting air in the system. And you can get air in the system not only by the patient or something else inadvertently decannulating the patient, which is rather dramatic. That will definitely get a lot of air. But it can happen through just very simple human error of the ECMO specialist. And so the more complexity you add to the circuit, going back to that slide we looked at, the more attention you need to pay to it. So if you have any access ports, positive or negative, the nurse at the bedside should not be managing the patient and the ECMO circuit. Whereas if you have a bunch of access everywhere, then a perfusionist is what ELSO recommends should be doing it. If you have some, maybe only on the positive side, then the ECMO specialist. Now, do I agree with that? No, I don't agree with it at all. I don't, but I understand the reason why, and it has to do with increased complexity. You have to be very respectful of it. The problem is that when you take away all of the available access, so there's no access The only thing you have is connected here to the patient and there to the patient, and you have your connection point to the, from in the pump, out the pump, and these can be solvent bonded in the oxygenator, out of the oxygenator, and back up, or tie banded, whatever the case may be. But you have nothing else connected to it. You have a circuit that you can't really mess up. You can kink it, you can yank the cannula out, but you can't turn the stopcock the wrong way. The disadvantage is you can't add anything to it. You can't really do a circuit gas unless you have something, port on the oxygenator itself, which is built in and designed that way. Because if you change if you modify the circuit of any of those other circuits, cardio help or anything else, the manufacturer warranty is voided. Anything that happens becomes your fault, not their fault, even if you weren't at fault for it failing, because you have modified the circuit. It's a legal thing, but it's something you have to be aware of and very careful of. But if you wanted to add CRRT to the patient, if you have no access available, you can't add it to the patient. So you see here an access port, pre-oxygenator for the CRRT. So you have the blood going this way through the hemoconcentrator, down, and going back into the circuit. So this is actually your access. This is actually your return. It's an access port. In other words, you can access it as opposed to the actual access for the CRRT. That would be here, and this would be the return. Okay, and it shows you that in the arrows. But you can do pre-filter replacement, dialysate, you can do ultrafiltration, you can do a variety of things without having to stick another catheter in the patient. Sometimes you don't have any place else to put the catheter. It makes more sense to put it right into the ECMO. So that's the reason you want to have access. And I'm going to go over there, and we're going to show you on the ECMO what it is I'm talking about with the system. Very good. Okay. So here we have our patient. Here we have our ECMO. We're going to go to camera 6. And you see our return here. Here's our access here in the leg. Okay. Now, we're going to need to see the ECMO flow and the ECMO pressures at the same time. Rotaflow easily to air come to the circuit than others. I didn't know that. David, did you hear what I said? So we're going to see what? I want to see the ECMO pressures and flow and this at the same time. So I need the screen split. Okay. Okay. Well, you didn't. So yes. So I didn't know that about the. So go to camera 1 if you don't mind, and I'll can talk. There you go. Thank you. Yes, Timothy. I don't have any experience using the Rotaflow. I mean, I've used it before, but really not a lot of experience. But yes, it does have a pre-pump port. And, you know, we, in our system, I have a pre-pump port. And there's a reason that I have it, and which I can articulate as when we get this to where I can demonstrate that to you. But it's something that is a subject of significant debate. You have shortage of perfusionists, although they've opened 12 new schools. For those of you who may not know that, they are generating a lot of graduates, and I believe that the number of perfusionists within 12 to 18 months, more than likely, is going to, for the first time in probably a decade, exceed the number of jobs that are available. And that is both good and bad. It depends on how you want to look at it. It's good in the sense that I think the really good clinicians will be the ones who stay employed, keep working. Those that are really dedicated to this profession understand that we have a tremendous responsibility. We make an incredibly good wage, and we have a very reasonable quality of life for the amount of money that we make, because nobody makes the kind of money we do and only works 40 hours a week. But there are a lot of perfusionists who make this kind of money and only have to work 30 hours a week or 25 hours a week. And if they have to work 30 or 35 hours, they complain quite a bit. I find that troubling. I actually am not, I have been discouraged, I would say, even though I love my profession and I want this profession to endure. My feeling is that we have not done a great job over the past several years at introducing people into this profession that really understand how significant it is to be professional and to be dedicated and very devoted to this profession. We're good? That is. Only we could, I don't know if it's possible, but you could make the left side a little smaller and the other side a little, the other side a little bigger. I need to see the pump itself, like a wide view of the pump. But anyway, with that said, I think that there are those that are like that, and I love those people, I really do. But I've also seen people come and go. They just don't want to do the job. They don't want the stress. They don't want the work. They feel that their work-life balance is horrible, and sometimes mine is. I mean, during COVID, I don't think that I didn't sleep. I was sleeping in my car in parking lot because I couldn't drive home. I was too tired. So it was challenging. There's no question about it. And this is a tough business. But again, we make a really good living, and it's very important. You know, and then on the other hand, you know, I'm encouraged. So I get discouraged, but then I'm also encouraged. I've seen some really good people, and I've worked with some incredible people and really enjoyed it very, very much. So I think it's mixed. I think the increase in the number of people is going to stabilize our economy, but it can also hurt us in the long run. Big organizations, big contract companies are going to hire people, and it's going to give them leverage and power. And to that end, it isn't good for our profession. So, you know, I've seen this cycle happen multiple times over the years, and I don't know that I have another 10 years in me. Cycles usually go about 10 years. I'm not sure I have another 10 years, but we'll see. And maybe some of you younger folks out there will kind of take on a project and help this profession to endure. Be part of the solutions and not just part of the problems. Find problems, but always look for solutions as well. So those are my comments, okay? And I know Ann is going to be here later on this afternoon. Ann Gretcho, she's going to get in around 3, and we're going to have we call it a fireside chat, but it's really going to be a dumpster fire chat. But we'll talk about that when we get to that. So let's get back to what we were doing. No, I want to see the ECMO circuit. So I want to see. So take that monitor and the monitor the pressures and move it all the way to the right and up, like, you know what I mean? Yeah, like that, and go way up. There, that's perfect. Yeah, that's beautiful. That's exactly what I was looking for. Say again? Yeah, that's good. You don't have to make it perfect. That's perfect. That's perfect the way it is. Okay, so we have our access line coming from the patient. It's coming down, and we have it tethered to the thing, and here it is here, and it's coming into the pump. And as I told you, anything on this side from here back to the patient is a negative pressure. And I could do this with the ECMO simulator, but I'm just going to do it with my fingers for the sake of this discussion. If you look, you see the flow is 4.13, upper right-hand corner, and the access pressure is 74, negative 74. If I compress this line, you see the flow go down, the access pressure goes up, and the return pressure goes down. But it's very important to recognize anything at any time from here forward to the patient is going to be negative. Anything from the pump out from this point all the way to the point of the patient is going to be positive. This is positive, this is positive, this is positive. The difference between the pressure here, just outside the oxygenator, and here is your delta P. This pressure will generally be a little bit higher than here because this pressure is only measuring the resistance at the cannula. This is measuring the resistance not only at the cannula but also through the membrane. If the oxygenator had zero resistance, then these two pressures would in fact be equal. Now, getting back to what we were talking about, this is a positive pressure. This line right here, we talked about that. We have the flow probe on it. It's post-oxygenator. It's post-pump. This is positive. Now, can you focus in, David, on this stopcock? And this happened to me just the other night. I wasn't the one that did it. But it doesn't matter whether you do it here or whether you do it here, it's going to have the same effect. If you want to run a blood gas, this is coming out of the top of the oxygenator and it's post-membrane. This is going to have the same exact blood gases as this would have. But if you by accident turn this stopcock, and we're looking at it, yep, this is what happens. You saw that? And if you have more realistic pressure, it does like that. And if it's blood and you accidentally, that stopcock gets turned, broken, is leaking, and it's down here, and you're standing, go to camera 4 looking forward, and you're monitoring your ECMO, and the nurse has gone to the restroom. From there, and zoom in a little bit. Just zoom in, doesn't matter where, just zoom in. And you're looking from there, and normally you would have your pressure and everything up here. It wouldn't be in this configuration. It's like this because we're doing this virtually. You can't even see where the blood is leaking. That thing could be leaking, and you could have a lake of blood down on the floor. You're going to start seeing the patient begin to decompensate. You can go back to the other camera or zoom back out or whatever. Yeah, there you go. You could have a, which camera am I looking at? So that's camera 4. Yeah, that's perfect. So, and then we'll go back to camera 6 here in a minute. So you could have a lake full of blood down here, and until the patient becomes hemodynamically unstable and you come in, you may not know it. So let's go back to camera 4 and zoom out. That's good. Okay, so now we're going to look at it from a different perspective. If you decide you want to draw a venous gas, you could draw it from here, but let's say you didn't have something here. Or let's say you put a stopcock, which is the biggest mistake you can make, directly on the connector, and somebody comes by and hits it and knocks it off. Could be a family member. You just don't really know. But this is what generally is going to happen, and I can turn this from any place. So do we have good sound? Can you hear pretty well? Yep. My microphone's on loud because I want them to hear this. Yes, turn it up. Mm-hmm. So, and you can see this. Can you zoom in on this? And this line right here, and the cone. And there's an air bubble detector right here. And we want the split screen. We want to see the other thing as well. That's good. And then put the patient monitor top right corner. That's it. Beautiful. That's perfect. Okay. And you see these right here? Green, no bubbles. And you know the Perfusion mantra? No bubbles, no troubles. But what's the little air among friends? Just remember that. If I turn this stopcock, it's going to come here. This is a negative pressure. If I turn it the wrong way, and this is how fast it happens, we're flowing 4 liters. You ready? I want them to see it. See that? That wasn't very long. And your system right now is full of air. It's actually pumping some of the air because of the configuration. It should be set like this to minimize that, right? But that is not a good sound. Can you hear it? And you hear the alarm going off. And you're going to have to get that air out. Obviously, that small amount of air for VV ECMO, if you're shunting the oxygenator back into the venous side, it's just going to go round and round and round. But eventually it may clear. But you do have a problem on your hands. You can use a syringe, you can do all kinds of things. But what it requires you to do is to take the pump off, turn your RPMs off. You're going to have to rotate this, get the air out, and some of the air's already been expelled, but you see that air. Of course, it'll be foam because it's blood. Put this back on, start it back up again, and you will see, you couldn't see it, but that air is going to make its way eventually out. So what I would do in that circumstance, if the patient is stable enough and it's going to be somewhat hectic and chaotic, is you would take a 50 cc syringe, but you would have to have it available to you. You would have taken a clamp. In fact, why don't we just do it? I'll show you how it gets done. This time I'm going to set this down here. So we're going to go through the whole process because you can't really shunt it back. So I'm going to do that all over again. Oh, that's positive. I have to do negative pressure. Okay, here we go. Okay. There's air. Well, I'll turn the alarm off, but I actually like leaving the alarm on. We're going to turn this off. We're going to clamp here. We've got our syringe here. We're going to turn the stopcock this way in just a second, but for right now, I'm going to just 45 it. I'm going to take this off. We're going to fill this, get the air out as best we can. If it's VV, I would not try to be perfect with it. Do the best you can to get the most you can. Then you're going to turn on the RPMs with that line clamped, open this, and start letting the air come out. And a 50 cc syringe would be better. If you only have this, you're going to probably take it. You're probably going to have to waste it. And then you're going to have to go, so I'm just going to pump it back into the circuit versus squirting it on the floor. And continue until you have expelled most of the air. And I can see it all collecting up at the top. And I believe we got most of it. May have to go up a little higher on the RPMs to get it to come out. There it goes. I saw it all. Turn this off. Take your clamp off, and you're good to go. So you have expelled the air from the circuit. Now, I'm doing it, and I'm prepared. So let's go to camera 4, 2. Camera 4 or 2, I don't care which. Do something. Okay, so I'm doing this, and I'm prepared. Could you imagine if you were sitting, reviewing the chart, doing whatever, doing something else, and you heard that? It's devastating. And if your patient was VA ECMO, much more complicated to get this out. If your patient was completely ECMO dependent, VV ECMO, much more stressful because they're going to potentially code. It's worse. It's harder to do this than it is to change the entire circuit out if you have another circuit, if you're doing it in a prepared manner. Obviously, any acute problem that occurs that's an emergency is so incredibly difficult to fix when it happens. But we can't be prepared for every catastrophic event. What we can do is we can respect the fact that these things are here, make sure they're on and secure, be protective of your ECMO circuit and area around the ECMO, and don't let people around it that don't understand it or cannot fix it. Because if this happened while you were in the restroom, which is normal for whatever reason, the patient it's done. It's done. And it'll end up being on you. So there's the reason why ELSO suggests that a circuit with no ability to do that is the appropriate circuit for the nurse that is at the bedside that's busy managing the patient, because there's a lot going on. You got drips, and you got labs, and you've got Foleys, and you've got respiratory, and you've got orders, all the things that nurses have to do, which is an enormous amount. And you're adding this level of complexity to it. Well, in a patient with a very safe circuit that this can't happen to, on cruise control, that's been on VV ECMO for 3 or 4 days and is going to be on for probably another 2 months, probably okay. But even in those circumstances, things can happen. Having a really good nurse ECMO specialist, respiratory ECMO specialist, whatever, who can manage a situation like this in a crisis, know what they can get away with, and be able to deal with it, I totally agree. But you really need, in the case where you have the ability for this to happen, someone who is trained to manage this. The nurse at the bedside, not that they cannot do it, and I want to stress this because I have so much respect for them and how hard they work and what they do. It just isn't fair because they have too many other things to do versus only focusing on this. And I think that's the differentiator, in my opinion. Okay, so I showed you air in the system. I showed you how it spits. I talked about the negative pressure, the positive pressure. Any comments from the gallery? No comments? Okay. Well, I hope everybody enjoyed that simulation. It was fun. Oh, and then when we come back, what time is it? Yeah, it's right about lunchtime. It's good. So we're going to take a break. We're going to come back at what time? 3 o'clock. Perfect. Okay, we'll see y'all back at 3 o'clock. Let's have an early lunch and a little bit longer for lunch, if that's okay with everyone. And we're going to do inflow obstruction, hypovolemia. That's a fun one. And then we were going to do ECMO Simpson scenario recirculation, but I'm not doing that. I'm actually going to do a different one. It's going to be just a surprise. We got to figure it out. Of course, I'll know what it is. but because I'm the smart one, right? Total decompensation of the patient for some unknown reason, and we're going to try to figure out what it is together. And then fireside chat. It's actually going to be Ann Grecho, not Min Tran. He's going on vacation to Cancun, and Mike Brown is also on vacation somewhere. So I scheduled this stuff apparently not well around their schedules. But Ann Grecho, our American Board of Cardiovascular Perfusion president, is going to be joining us here in the studio for our discussion period after, which is going to be about ECMO. Where is it all going from here? Okay, thanks. Let's have lunch. Hey, and welcome back, everyone. Good afternoon to the second half of PerfWeb 82. We're going to do two scenarios now. The first one is going to be a little bit basic, but interesting because common. So I wanted to go over that. And then the second one is going to be a lot more complex, but I'm not going to share with anyone what it is. I'm just going to run through the scenario because usually what I do is show what it is, kind of talk a little bit about it. I think and then go through it. I think that's very instructive, but really at the end of the day, we generally don't have that as an option or an opportunity for us. We just get confronted with a situation and then we have to go through the various algorithms to figure it out. Everything good? Hold on. Because I'm standing here talking and I'm not sure they even hear me. Is it working? Okay, hold on. Oh, we're good. Okay, so everyone did hear me, I'm assuming. Okay, Matt. Signal's going out. Okay. Yeah. Okay, good. All right, fantastic. Okay, so let's go ahead and do that. Oh, I had done it. So I need to, I'll click to begin broadcasting. I did turn it on, but it turns itself off. So how's that? It says it's broadcasting. Yes, that ventilator. No, then every time I turn away from it, it stops. 3, 2, 1. Okay. It says it's broadcasting. It's blinking red. Okay. All right. There we go. Nothing like a little confusion to get everything going between 12 and 3. This is kind of an interesting way that we did it. We did this morning, of course, and then we took a 3-hour break. And we went and had lunch, and I fell asleep between lunch and now, which then put me in a fog. And I was like, oh, my God, we got to go. We got 7 minutes to go. David made the comment to me that it was an eternity. 7 minutes, that's plenty of time, which is true. Okay, so continuing to move forward, we have our ECMO patient here. We're going to go ahead and do this scenario. I think you'll find it interesting. This is a very common occurrence that we see frequently, and I'm going to highlight some of the things that the eigenflow ECMO simulator can do. So I'm going to take this and I'm going to come over to there. And let's see. I'm going to go ahead and get the simulation going. There we go. And this is just like I said, it's a very common occurrence. There you go. Good. All right. So let's go to camera 6, and you can just bring it up here because I'm going to work in this area mostly. Okay, there you go. And we want to go ahead and get our flow up. Okay. Okay. So if you notice on the, you can go to the multi-pack. You're starting to get some alarms. And you're starting to notice that, you'll start hearing the patient monitor may go off first. You hear the ECMO going off. And what you're seeing is the flow rate is fluctuating back and forth, back and forth. And if you're not looking at the control, well, that's why it's so important. And one of the things that I think I like to stress is you have to have a visual. But you see, the patient sats are coming down. You're going to start noticing that. But it's not to where you're having the patient completely crash right away. This patient, of course, is on the ventilator. They're somewhat ventilator dependent. But the ECMO is still working, but it's very back and forth, hit and miss. And you notice down here that your return pressure keeps jumping up and your access pressure is there. Now this can go a different way, which is actually what my intention was. So I need to redo this. It may take it a second to catch itself back up and see if it will do it, because I kind of started this scenario out being a little different than I wanted it to. So let me try this. Let me reset this. There we go. Let's try that again. Only this time, I'm going to do it this way. And what you're going to start noticing here in just a second, at least I believe, you got to love technology. And let's give it a second, see if it'll catch itself up. Patient may be recovering a little bit, which is good. And I can't quite get it to work, Magic. I'm really struggling here. It says it's doing it, but I don't really see it doing it. Oh, it's not. Oh, okay. Well, that's a problem. Okay. Let's try it now. Okay, so this has to connect via Bluetooth, and it was saying that it was operating, but it wasn't connected, and Magic was able to see that because there is a light that will indicate that. And let's see if we can get this to do what I want it to do. Oh, you gotta love technology. I'm struggling, Magic, really bad. Oh, I think I see the problem. Okay. Yes, I see the problem. It's because this is turned, this needs to be turned that way. Okay. So now that we got that corrected, I think maybe it'll work better. There you go. Okay, so it was operator error on Joe's part, and but what you see are the fluctuating flows. It's just kind of enough to keep the patient from completely crashing, but if you look here, you notice that the access pressure keeps fluctuating very dramatically, almost to negative 200, and then it starts to release a little bit, and that's correlating with these flows. So what's happening here is the cannula, the patient is, the problem is, of course, hypovolemia. What is the appropriate thing for us to do? So we want to give the patient a bolus of volume. And usually 250 albumin is very helpful in this circumstance. You can maybe go up to 500. I think we should measure the albumin. It really does help quite a bit when we do that. The question is, where do we want to administer it? Do we want to administer the volume into the patient, which will take a little bit longer, or do we want to administer it into the ECMO circuit? And I do want to show you this if I can. So we're going to give the patient 250 of albumin, and not long after we do that, and it doesn't take very long at all, it's going in, and like I said, the real question is where we give it really matters. So it's going in, and you'll start seeing these pressures the flow will start to be more consistent. I froze. I'll tell you what, guys, this afternoon is really falling apart on me. I'm frozen. Magic, I am frozen. Do you understand I'm frozen? I know. I'm just trying to tell you. I'm not. It's okay. Here, can we switch a camera? Go to camera one. Okay. So this afternoon's going to be a dumpster fire. I can already tell. But so I'm not sure what's happening. Maybe let's go to camera 4 and look at this and see if we've gotten that resolved. And Lord have mercy. Can we? Can I ask a favor? Can I ask a favor, please? Can we take a break? Everybody, I'll be back in 2 minutes. I need to stop. It's on now. How much of that didn't go through? How much of that didn't go through? I turned it off. Yes.
That's why I said don't turn your mic off. It's always going to be off here. I'm never going to let you be live.
Okay.
Never going to let you be live.
All right.
Yeah. I'm never going to let
So was all of that dead air?
It was all dead.
Okay. So okay, so let's go to the last scenario. Okay, give the volume. And where do you give it really matters. You can give it here into this section, but if you do give it here, remember, this is the negative pressure side. Remember what we talked about. If you put it on an albumin bottle and you're venting it, and you turn around and you're not paying attention, and that albumin runs out, it's just going to fill this full of air. So it's treacherous to do that. You have to be extremely careful. It's very dangerous to do, as a matter of fact, unless you are trained. You have to do it that way for some reason, and you are really, really paying attention. It is something you have to truly pay attention to. So keep that in mind. Okay, so I think that scenario was a bust, and we're going to go right into the next scenario, which I think is going to be a lot more fun. And just to get off of this camera, David, it's something else. I don't care. Yeah, I just need to get this cleared out and be ready to go. Okay. All right, there we go. Okay. So all I can do at this point in time is welcome everyone back. And we had a great afternoon, and we're going to start our final scenario of the day. If you want me to redo the hypovolemia one at some day, I will. But at this point in time, I'm feeling like hypovolemia is a very bad scenario for me to do. It doesn't seem to work out too terribly well, so we're going to move on. So let me find the one. Yes, this is perfect. Okay. So let's make this a little bit better. And I want to go... Something's not right there. Okay. There you go. Now we're there. Okay, let that settle itself out a little bit. And we'll get our ventilator simulator going here. Yeah, that's good. That's perfect. Perfect. Okay. All right. Let's go ahead and start this scenario. All right. I'm not going to tell you what the scenario is. We're simply going to just go through it. The patient is cannulated, femoral venous for access, femoral arterial. This patient has been here. Don't know slides, but this patient is a 44-year-old female. She has been on ECMO now for the past 36 days. Her lung compliance has not improved much at all, and we're basically just operating on we're keeping the patient alive, trying to figure out what we're going to do. Is this patient a lung transplant candidate? To be a lung transplant candidate, you have to meet certain criteria. You have to have the financial means for lung transplant, whether that be through insurance or otherwise. You have to meet a certain age requirement. You have to be able to demonstrate that you can participate in your care afterwards. So many of our ECMO patients, what we do is we put them on ECMO, we wake them up, we trach them, and we walk them up and down the hallway. Some hospitals require you to demonstrate that a person can participate in their postoperative care after transplant. Other centers want to see the patient be able to walk at least 100 feet. And so you cannot have other significant comorbidities that would be a problem, whether it be renal dysfunction, hepatic complications. You can't, generally speaking, if you're a diabetic, I don't know that that's absolutely an exclusionary criteria, but it certainly doesn't help. You can't have any neurologic problems. You have to be really almost perfect otherwise, and I'm talking lung transplant here, but almost perfect other than your lungs are not working. But you have to, so it's very important for us on these patients who have really just bad lungs, just not reversible lung disease, that we have to get them awake. So we can't keep them on neuromuscular blockades. We have to get them extubated. We were doing awake ECMO, as a matter of fact, thinking that if we don't intubate them at all, that's going to help them quite a bit. But that was difficult. And many of the patients that we did that with, we later still had to intubate in order to get everything calmed down. It was a difficult time, but you're definitely going to be better off. Now, in this particular scenario, you notice we're just watching the ECMO. And like I said, ECMO is a very, I mean, this patient's been on ECMO for 46 days or whatever it was I had said. It's been on ECMO for a long time. We see them day after day after day. And you notice the patient's blood pressure isn't looking very good. And this generally is how it happens. You just look up and you go, what's going on? Patient's blood pressure is down. Patient's saturations are down. Patient's heart rate is going up. Your flow seems fine so far. I don't see any real issues with the flow yet, but things are starting to look problematic and you don't understand. You're sitting there trying to figure out what really is going on. And then over the course of time, you start to notice that your ECMO flows might start to also come down, which in this case they did. And this is a case that I actually did. I was dealing with this case and trying to understand, figure out what exactly was happening. And it was very interesting because what I actually found was by luck. And I just was sitting there looking at the ventilator at the time, and I can't simulate it with the simulator that we have. It doesn't give me that option, or at least I have yet to find that option. But obviously we're having a problem, and what started it all off for me was I said, you know, we got to do something. So the first thing, let's get 100% oxygen. It was to no avail, but we still did it, and it's the appropriate thing to do. If you weren't 100% on the ECMO, which we are, you would want to turn that up immediately. We're looking at the patient. We went and we did, let's put the patient up large if we can. We went and, can we put the patient up large? Yeah, well, they're not quite there. I can't. The patient's kind of obstructing everything. See the monitor, what I'm looking at? I can't really move on. There you go. Okay, so we're looking at the patient. We're checking the lines. We're checking the cannulas. Everything is looking fine. We can't quite figure out what is happening with this patient. And as I said, I kind of noticed it when I was looking at the ventilator. and something caught my attention, and that was the VTE and the VTI. And I noticed that that's the tidal the inspiratory VTI is the inspiratory tidal volume, the E is the expiratory tidal volume. And you see this patient's tidal volume is 73 cc's, and that's VTI. The VTE was 20 cc's lower than that. And we're breathing on this patient 15 times a minute. So if you take 15 times 20, that's 300 cc's every minute. And that 300 cc's was going somewhere. So was it the sensor? Well, what was going on? Well, I'm looking at a very hemodynamically unstable patient. So I said, well, okay, I think we need a stat chest x-ray because things are not looking good here. So we did a stat chest x-ray. And this is what we found. And this is a real patient. Can we bring that up large? Yeah, perfect. So take a look at this. Nice big tension pneumothorax with the lung, the left lung, pushing everything over into the right chest. And this was the cause of the hemodynamic instability. And why our volumes for the ECMO, I was having problems because our access pressure was going up because blood wasn't making its way back. It was being obstructed. So I want to do something here, and I hope you can make the patient big now, if we can. Yeah, beautiful. And let's go to camera 6 and just go to the primary view. Okay, there you go. You're on camera 6. Perfect. So the appropriate treatment for this is a chest tube. And so we're going to put a chest tube in the patient. And as soon as we put the chest tube in the patient, and so see, I wish we had that Mevo camera facing this way because it would be better to see it. But that's okay. Oh, that's okay. We don't have to worry about it. Okay, so we're going to put the chest tube in, and it's here. And as soon as we put the chest tube in, and I'm going to go back to that x-ray investigation. So can we put the x-ray back up, David? There you go. And just make the x-ray big. So no sooner that we put the x-ray in, we started to look a little bit better, but immediately we got worse again. And I was like, well, what the hell is going on? And I noticed the exact same phenomenon. And there's the x-ray immediately after putting the chest tube in the left side. She blew out her right side and had the exact same problem going on. So what did we do? We called them back. And the intensivist came back, and it actually was the nurse practitioner. She did a fantastic job. I remember that day. And we put a second chest tube in to the left chest. And can you see that? 2 chest tubes. There you go. That's perfect. And then let's go back to the monitor. And no sooner that we did that, everything started to get better. And the patient over time, you see our SATs have come up, our heart rate's going down, our pressures look better, our flow is better. Everything is looking better. So this whole situation occurred because of that issue of the lungs essentially developing a big hole. They essentially just exploded. I don't know how else to explain it. And I've actually seen these lungs where we've opened the patient up with thoracotomies, and we could actually see these were with lung volumes very low pressures of, but the pressures were much higher than 20. They were more 30, 40. And I've seen the lungs so stiff you could see the holes. They clip it, and then another hole would develop. So that's what happened. We ended up with a right-sided pneumothorax, and then which became a tension pneumothorax. Then, as soon as putting a chest tube in, a left-sided pneumothorax, and it was all picked up because the VTE did not equal the VTI, and that makes so much common sense to me, but I really noticed it by happenstance. But anyway, now everything is running very well. So happy about that. All right. So I think we have about an hour to go, right, before we get Ann here? 3 to 4. Yeah, she's going to be here at 5, right? About, yeah, the last hour. Yeah, so why don't we go to quick break, and we will run back and start that hypovolemia scenario over again. So I'm just going to reset it back up. Would that be okay? All right. Thank you. Nothing's moving. Okay, hey, and welcome, welcome back, everyone. We just had some fun. Okay, so I wanted to go over some things and just talk. I needed to sit down. Doing an entire day of these simulations by yourself is at the very least challenging, especially when you get to my advanced age. But you know, we're also still learning, so I do appreciate your patience. Uh, I'm sorry, growing pains. Yeah, it's called growing pains. And man, I'll tell you what, when you do stuff live, it can be really hard. Anyway, Perfuse find, my good friends from Spain, arterial cannula thrombus. So no, that wasn't the issue. I think you figured out what the issue was. It was hypovolemia, and that was the issue. Or unless you're talking about the, was that during the patient with the? It depends on whether you're talking about with the pneumothoraxes or you're talking about the volume. But yes, the hypovolemia was the other one. So I'm not sure exactly when this came in. I didn't see it. Magic said he popped it up, but I didn't notice it for a whole variety of reasons. But I wanted to talk about ECMO and just take a few minutes. And then what I'm going to do after that is we're going to do another simulation with our ELSA meter, and we're also going to do some things with our app that I'd like to highlight for you guys because I think they're really valuable and worthwhile. But, you know, ECMO is by and large a game of hours and hours and hours of boredom followed by some things to do to help the nurses, followed by noticing something and investigating it, but finding out that it's nothing. It could be I need to administer a unit of pack cells, which we can do into the pump, or you can just let them do it with the nurses. That's not uncommon. I know there's a big dislike to adding volume to the pump, that it's gonna, like platelets, so it's gonna, all the platelets will get lost in the oxygenator. Well, that's really not true. I mean, but I know people believe that, but it isn't accurate. You can give platelets into the pump. It's not going to filter any more or less out than it would be doing already. And if you've been on ECMO for several weeks with the same circuit, which I'm not sure is a good idea because that's a different topic, but a conversation that I think it's worth having. Most of the time that you spend watching ECMO is going to be, you know, just there, just in case. Now, when there is a just in case moment, you just never know when it's going to be. It really helps to have the experience to be able to deal with things that happen. That case that I talked about where we had the bilateral tension pneumothoraces was just, you know, I mean, somebody else would have eventually said, well, I mean, let's go through the algorithm here. We need to get a chest x-ray as part of that algorithm. It just would have made sense. But before the radiology showed up to do the actual x-ray, I knew that patient had a tension pneumothorax. And of course, I've been doing it for over 40 years, and that helps. For those of you who may be younger in your career, that can be a very frightening circumstance, not understanding what is wrong. But my message to you would be you just have to sort of think it through, take it step by step, try to figure it out, and learn, because you have to you have to go through some of these experiences. You can only read and remember so much. You remember best when you actually live through a circumstance. So I wanted to add that to this. But most of the time, you really spend your time doing very little, unless you're weaning or you're doing things like that. I do want to talk about settings on the ECMO circuit. One thing you definitely do not want to do is to wean a VA ECMO ever by decreasing your FiO2 on the ECMO circuit. You never do that. I've seen that happen a couple of occasions. VV ECMO makes sense. VA ECMO, absolute no. Now, if anybody disagrees with me or somebody feels differently for some reason, please call in, text in, chat in, whatever it is you want to do. So keep that in mind. All right, so, but VV ECMO, that does make sense. And then I want to talk about this idea of capping the membrane. A friend of mine brought this up, and I was like, what are you talking about, capping the membrane? And they said what they do is they clamp the actual oxygen line going into the oxygenator and I can't remember the reason they said. I don't think that makes any sense because you're really not capping it off because you have a gas outlet port. We're going to explore the oxygenator over there in the circuit in just a second. But after we do that, I want to talk again a little bit about hypovolemia. We're not going to pull everything up. We're just going to do it over there and look at the patient because sometimes you don't even see it on the monitor. You'll just see a little shiver, and when you do see it, a little jump in the line, it'll catch your attention. And, of course, that means you're there paying attention. If you're really deep into a book or a movie or YouTube videos, or you're not on the unit and someone doesn't notice, it usually starts off with something very subtle, very minor. The patient has no consequence to it whatsoever. And then over time, it just gets worse and worse and worse until then you start seeing some change and alarm is going off on the monitor, whatever the case may be. Now, does that mean that, oh my God, you didn't see that? And it doesn't mean that it's going to have negative long-term impact on the patient. And I think that's important to recognize as well. These patients are very sick. They're going to be there for a very long period of time. There's going to be many occasions where they're going to have severe hypoxemia, severe hypotension. There's going to be all kinds of things going on and happening to them at any one particular period or moment in time. But by and large, hypovolemic chatter is not something that is catastrophic by any means unless you just completely lose your flow. Now, you have to ask yourself, is this happening because of hypovolemia, or is this happening because you're starting to develop some clot? So obviously you have to be pretty sure that your anticoagulation protocol is okay, that your anticoagulation status at that moment. If the last PTT you got back was 34, you might want to start being real concerned that chatter might be from another reason than hypovolemia. If it was 56 or 60 and you're flowing 4 liters a minute or 4.5 liters a minute, 5 liters a minute, even 3.5 liters a minute, the likelihood is very, very high that thrombus in the line is not going to be a problem, though that has happened to me as well. And I have a nice picture of that, as a matter of fact, which I find in fact, you know what? Can I show it to you? Let me grab it, because I want to show you this. This is a very, I think, instructive and informative picture. I'm going to come back over there, David. I'm just going over here to grab my phone. Yay. I heard from Ann, and she's going to make it. She's on her way from the Memorial Southwest area, so she should not be too terribly long. That's fantastic. Take her about 45 minutes to get here, and she's coming in as the cavalry, and she's going to really bail me out. But I want to show you this picture because I think it's. Can I share my phone? I think. Mm-hmm. All right. Start broadcasting. All right. There we go. And I'm going to pull up my photos and let me find that photo. I'm the world's worst. I just saw it earlier by luck. And then I want to show you some more things on the app, which I think are worthwhile before we go back over to the ECMO. This is an interesting picture. I want to show you this. This is probably not really the thing, but I have never in my life seen an aortic gradient that high before. So you see the aortic pressure is 82, and the pressure in the left ventricle, the higher one, is 220. So that is the highest gradient I have ever seen in my life. All right, you can take that down. I just wanted to stop and show that picture. Yeah. There you go. You probably don't want to show all those pictures. That could really get bad. That could be bad. Exactly, exactly. Completely understand that. I think I'm getting close. Okay, all right, throw it up real quick. Here's a picture of David on a video. Well, we're not, there we go. We're seeing it, yeah. And remember this? Where did we do that? I don't remember where that was. That was fun. Yeah, you can take that away. That's my daughter. Can you take it down? Yeah, you took it down. Thank you. Let's see. I know I'm getting there. Mm-hmm. 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 I probably should put these in certain categories, don't you think? Mm-hmm. Okay. Anybody want to say anything? Do we have any comments coming across, Magic? I really want to find this. I probably should have done it earlier. But now I'm committed. I can't abandon it. I have to do it. You ever been like that where you just can't stop? Like, I'm committed. This is going to happen. I have to show it. I have to find it. And it was funny because Anne was there. And the reason that I thought of it is because she's on her way to do the Fireside chat, which is actually conversations in the at the Inferno. How do you say that, David? 5-alarm chat. Yes, conversations at the Inferno. That is correct. I'm almost there. Pretty sure I'm getting there. There it is. Found it. Okay. Yeah, let's put that up. And can you make that any bigger? Or how can I make it bigger? Turn my phone sideways. You don't worry about putting me in the picture. Just blow it up right over me. And look at that. What you see, I don't know how I can actually point to it. There's no way for me to point to that, is there? That's perfect. You can actually see the clot. That's okay, David. I don't need to be in the shot. So is there a way for me to point at it? Oh, okay. Can you put it at the green screen? Okay, dude, put that on the green screen. That is such a good idea. I like that. Okay. There you go. Okay, so what you're seeing, there's the clot. And and this white thing here, I'll show you over there, actually is part of the pump. That isn't anything to do with it. But what you're seeing here, this ring, this corona that you see, is actually cavitation and air because there's no air in the circuit, but air got pulled out of solution, and this is a big ring of air, and you're seeing the white of the cone, and it was so incredibly remarkable. The thing is spinning, and it just created this pocket of air. So there's blood here, air there, blood over here, and you see this big clot right here. And of course, we had to change this out. We changed the whole circuit very, very quickly. But that was, I'm going to go back over here. But that was during the time when we were doing the zero anticoagulation. Okay, so let's go over our app. I want to show you our app because I don't think we spend enough time with that. I still should be sharing. So, is it not NDIing? Okay, begin broadcasting. I don't know why it kicks me off. Yeah, okay, there you go. It's back on. So, let's go to our main app, which is this one, the Critical Care Perfusion app. And you can get this on the App Store. You can get this on Google Play, whatever the case may be. But since we're doing ECMO, let's go through all of these things that we can do. So if you're an ECMO specialist, I think this has great utility. The PaO2 is 87. The FiO2 on the vent is 70. Calculate. Your PF ratio is 124, and as I described earlier, you can see it's red. If you look up in the top right, you see that little eye. If we click on that, it's going to give you information. It's going to give you the equation this is based on. It's going to give you the parameters and units. It's going to give you about the equation parameters, the outputs, and about the parameters. So whenever you have a PF ratio that is under 300, because let's see what normal is, right? Normally, we live off of a PaO2 of, I'll just say it's 100 even, and we breathe 21% oxygen as a general rule. My PF ratio is 476. So basically, if you take into consideration that anything under 300, you need to start being concerned. Under 200, you really need to be concerned. Under 150, that's pretty indicative you need to be on ECMO. And anything below that, you really do. So I have seen many patients with PO2s of, let's say, 67, and they're on 100% on the vent, trying to get them stable. And that's a PF ratio, as you see there, of 67. That's very, very, very bad and very severe. So you really need to get that patient on ECMO. You have an ABG interpreter. You can take a pH that's 7.30. That's an acidotic pH. We'll give you a PCO2 of 50, and we'll give you a bicarb level of 26. That is going to be what? Everybody should know what that's going to be. It's going to be respiratory acidosis, acute respiratory acidosis. Why acute? Well, it's acute respiratory acidosis because you don't have a bicarb level that's really abnormal. Again, you can click the eye, and it's going to give you 4-step guide to ABG analysis. It's going to give you what respiratory acidosis and alkalosis is, metabolic acidosis and metabolic alkalosis, and what that looks like in an acute phase, and be able to interpret those. So you can very quickly look at a pH and a PCO2, and really those are the only two things that you need to tell whether or not the patient is metabolically or respiratorily acidotic. You can tell immediately just based on those two numbers. The Murray acute score for acute lung injury, very important. If you have consolidation in all 4 quadrants, you have a PF ratio of let's say less than, well, we'll say 100 to 174. You're needing PEEP 6 to 8. Your compliance is 40 to 59. Calculate, and your results are 2.5 points, mild to moderate, not eligible for ECMO. So it gives you that information. If we changed the compliance and calculated it, let's go the other direction. That gives you 3 points. That's severe, and so your Murray lung score would be 3. It's severe, eligible for ECMO. So it gives you that information right here at your fingertips. Your oxygen content, AVO2 difference, so you can calculate that. Your arterial oxygen content, that gets used in a whole lot of formulas, especially DO2. So, and I think it's so interesting to look at. So your hemoglobin, I'm going to put as 10. And these are so I can remember the numbers. Your SaO2 is going to be, I'm going to make it 98. And I'm going to give PaO2 of 110. So 90, 10, 98, 110. That's going to give me a arterial oxygen content of 13.67. If I change the PaO2, so remember 13.67. If I change this to 150, not changing the saturation, it doesn't make much of a difference at all. If I change the saturation to 100%, again, it didn't make much change at all. But if I change this hemoglobin to 12, it makes a little bigger difference. If I change it to 15, it makes an even bigger difference. But you'll notice, oh, I didn't make it 12. I made it that. I'm sorry. I'll make it 14. Look, now it's normal. So it's green. And it's 17 mLs per deciliter is considered normal. And so anything below that, actually it's 18, I'm sorry, is considered normal. No, 17. Yeah, 17 to 20 is considered normal. Anything below 17. So this makes an enormous difference. If you start off with a hemoglobin of 14 with these parameters, a normal CaO2, but we knock your hemoglobin all the way down to 8, it goes all the way to 11.35. And this is what I was trying to demonstrate. Your SAT's 100%. If I make, so let me see, what's that number again? Let's go back and remember that. 11.35. Help me remember that. I could change this to 300, double it. It only took it from 11.35 to 11.81. Almost no difference. But if I go back here and I make this, I had this as 150, it should be 11.35, but I add 2 grams of hemoglobin and make that 10, it takes it all the way to 14.07. So of course, we all know this as perfusionists and medical practitioners. Your hemoglobin is where you get your arterial oxygen content from, not your PO2. It's very, very, very minor contributor to that. You can get your mixed venous oxygen content. You can get your oxygen delivery. This is the new thing now with goal-directed perfusion, right? Your cardiac output is 4 liters. Your CaO2 is a little bit low because you're hemodiluted, so I'm going to make it 15. Your DO2 is 600. You would have to increase your flow. We'll go to 5 liters per minute to get it to normal. So 700, I believe it's 700 and higher. No, 750 and higher to 1200 is normal. So 750 is your floor on that. So you need a cardiac output of 5 with a CaO2, arterial oxygen content of 15 milliliters per deciliter in order to reach a normal DO2. But that normal DO2 is not predicated on a patient on bypass who is anesthetized completely, is paralyzed, and is cool. So all of those things are going to play a role in what is your actual required DO2. So you have to take all those things into consideration. You obviously have your DO2I, your index, if you like to use that. You have an oxygen extraction rate, which you can measure. You have oxygen consumption that you can measure. You have SVR, colloid oncotic pressure. If the globulin is 4, no, make it lower than that. Your globulin is 2 and your albumin is 4, and calculate your COP is 24. Albumin is your primary driver. If you have an albumin of 2.1, you can see your COP drops dramatically down to 14.35. So third spacing could be, in fact, a problem. This is something I think is really, in my view, underappreciated in whether it be ECMO or whether we went through that phase where we didn't want to give albumin at all. No, it's going to hurt the lungs. Well, no, it's not going to hurt the lungs. If you have a capillary leak, it's going to hurt everything. But that's a capillary leak. Capillary leak syndrome is a completely different thing, usually associated with sepsis, but severe inflammatory response syndrome. Generally speaking, you don't. But if you leave your albumin level low, down 1.8, 2.0, 2.1, that is actually an independent indicator for mortality. So correcting the albumin is hugely important to keep volume from third spacing out and keeping it in the intravascular space and actually reclaiming some fluid from the tissues where you may have generalized edema of all of the organs, and there's a lot of organ dysfunction associated with that. You can get your O2 transfer rate. Very important to decide, is my oxygenator working or not? If your SaO2 is 100% and but your PO2 is running low and your SVO2 is, let's say, I'll make it 60, your hemoglobin is 10. Well, actually, I take that back. You have to pick a hemoglobin of 13. There's a control, and that's because all of the oxygenators are rated on a control of 13, and then pick your flow rate at 4.5 liters per minute. That's going to give you an O2 transfer rate of 0.31. And you can look at that and look at what it's rated as. And this should be 4,500. We need to change that so it's liters per minute. So it gives you an O2 transfer of 313 milliliters per minute, which is usually, that's pretty good. But they're all rated at a hemoglobin of 13, so there's a control. I showed you the E-cylinder, and for those who didn't see it, if you look at it and you have 600 cc's left in the tank and you're flowing 4 liters per minute, you have 52 minutes of oxygen left in that E-cylinder tank. So I think that's very worthwhile. An ECMO selection algorithm, and this is for patients with refractory hypoxemia and a Murray lung score of between 3 and 4. You have to go through and ask yourself, is this cardiogenic, is there cardiogenic shock? If there is, but the cardiogenic shock is due to hypoxemia, you click this, and then you ask, it'll give you, due to hypoxemia, you want to do veno-venous ECMO. If your cause was for another reason, your cardiogenic shock, all other heart failure, then you want to do veno-arterial or veno-arteriovenous ECMO, which would be VAV ECMO, right? And then you can go back to this without vasodilatory shock. You just want veno-venous ECMO. So if your Murray lung score is 3 to 4 and you do not have any kind of cardiogenic shock or vasodilatory shock where you need circulatory support and pressors are working versus not, then you would just do VV ECMO. But very important, because I've seen this before where the patient was decompensating. They had obvious cardiogenic shock, but the patient was very, very hypoxemic. And I thought they were going to do VA ECMO. It was Dr. Matoyer decided, no, I'm doing VV ECMO because I think the heart is failing simply because of the lack of oxygenation. And in fact, that is what the algorithm says. We did VV ECMO and their heart perked right back up again, and that patient went on actually to do fine and went back to work at the same hospital where we were, where he was an employee. So I thought that was very interesting. Okay, there's the app. Let's talk about the ELSA-meter a little bit, if we can. So for those who may have missed that earlier, so let's go to camera 6 and let's look right at the ELSA-meter here. So the way the ELSA-meter works, I'm going to turn it off and then just turn it back on. Okay? And let that come on. So essentially, Transonic is a flow meter company. Here, can I do that? You're looking at me? Can you see? Okay, is a flow meter company. And they do TTFM. Many out there may be familiar with the Medi stem, but these are the original designers of TTFM, which is transit time flow measurement, and TTFM. And they use it for the coronaries, you can use it for the aorta, you could use it for the carotid, a variety of different places. But these are the folks that developed it. And they have an engineer that works with them. His name is Dr. Kravitsky. He's been out here before. In fact, he taught us all how to drink Moscow mules the Russian way. That doesn't make Magic happy. Magic is from Poland. He thinks Russian vodka is terrible. He prefers Polish vodka. It's true potato juice is what he calls it. Anyway, this device, he designed this some years ago. It's really interesting because I had never heard of it until probably 3 or 4 years ago, and it is able to measure recirculation in your ECMO. And recirculation in your ECMO is something that can happen with a fairly high degree of regularity, and so important to recognize because it really makes a difference as to the effectiveness of your therapeutic modality vis-a-vis the ECMO. Now, you can only measure recirculation in VV ECMO. You can't measure recirculation in VA ECMO, but the device also measures oxygenator blood volume. So I want to go over how we run the test. So let me grab my, oh, there it is. So this is my cup, and in the cup, for the purposes of this, I have water with just a touch of vegetable glycerin. And the reason I'm using that is that this has water in it, distilled water, and the ECMO simulator, or the circuit that you see here running. And so we need something that has a different density for it to analyze it. Normally, this is filled with blood, and we use sterile normal saline and inject it. There are some challenges when you use this with, let's say, the cardio help, because the cardio help and the oxygenator and the centrifugal cone are incorporated in a single unit. And Dr. Kravitsky has some very interesting videos that show the flow propagation through it. It's going to be very different than it is with our system that you see here. But let me just go through the whole process with you. So the first thing we're going to do is we're going to add a patient. And it's very intuitive, very easy to use. Can you focus in on this a little tighter? There you go, so people can read it. Yeah, and just maybe down a little bit. So it's kind of in the middle of the screen, a little more. Oh, okay, that's as far down as it goes. Okay, so we're going to add the last name, and we're going to call this fella. Can we pick a name for this guy? I know, Skradalovich. How do you spell that? That's Magic's name. No, we're going to do that. So we're going to call him, we live on Rule Lane, so we're going to give him, or the studio is on Rule Lane. So we're going to call it Rule, and we're going to give him a first name of Magnolia. So we're just going to call him Mag for short for now. We'll just call him, yeah, we'll just say, let me take that back. I messed up. Add patient. Yeah, it's got a very nice touch screen. RUEL, and I'm trying not to have my head in the image, so it's maybe a little hard, and I'm using my bifocals. All of this is hard to do, and we're going to call him Mag, M-A-G. All right, and we're going to hit OK, and we're going to give him a medical record number of 43567, and click OK. So at this point in time, and we'll add patient. We can do, well, okay. Find patient. Let's try Mag. Man. Okay, find patient. What did I say his last name was? Rule, right? P-Q-R-R-R-U-E-L. There he is. Okay. Measure patient. There we go. VV ECMO. You could pick either. Recirculation and oxygenator blood volume, and we can do this. But we can also go here and we can monitor flows, and we can set flows, and we want to display 2 flows. So we're able to display 2 flows, an access flow and a return flow. And you may ask yourself, why is the return flow here? And can we show the ECMO circuit? This part, the monitors. Yeah, those. There you go, 2.7 liters. So it's correlating with the 2.8, but yet you have that coming out. I know what the reason is. If I turn this way, and if I go over here, and I clamp this line, which is actually a shunt that I use to do this, you'll see that those numbers are now all coming back into agreement. Now, there is a difference between the ECMO flow meter because none of these probes, and Transonic will do this, have not been calibrated, but you see now that on the ELSA they're both reading exactly the same, and that's because I clamped that line over there. So I'm going to go up on the RPMs a little bit and get my flow up to about 3.2, 3.32. That's good. And I'm going to pull up some saline. Now, what else this is really good for is that, and in adults, we just pull up 20 cc's. That's usually pretty good. And what this is also good for is if we had cannulation, let's say we added another venous, I can take that arterial probe, reverse it, put it on the other venous, and be able to measure the return flow and both access flows simultaneously. If we added another return cannula, let's say in the left subclavian, so we had 1 access, 2 returns, or we went VAV, put it in the femoral artery, I can have flow probes on all 3 of those lines and be able to fine-tune by restricting the flow to the various returns to get the combination that I want. So we're going to accept this, and we're going to measure the patient. So we're going to go back, and we're going to go recirc oxygenator blood volume, click OK, and it's going to go through a countdown. Now, for those of you who weren't here for the first part of the lecture this morning, we want to know how much, what it's asking is how much volume is in the line from the place where I'll inject to the inlet of the oxygenator, which is here. That's going to be about 20 cc's. So about how much I have in my hand here, maybe just a little bit more, but it's wanting to know this for oxygenator blood volume. You can measure it or just be consistent with whatever you do. With the cardio help, because you don't have a line like this, it goes directly into the inlet where the cone is. you can't actually, when you give it, there's no straight line. It's going to all be mixed in that cone very rapidly, making it a little more difficult. So for CardioHelp users, I think they're coming up with some solutions, but other than cutting a line in, which you really can't do, it's almost impossible to use this when you're not using a separate centrifugal cone and oxygenator in this configuration. And Dr. Kravitsky can explain that to you probably better than I can. So we're going to put this at 20 cc's, and we're going to click OK. Now, it's telling me that I can, when countdown is finished, it will give me the option. It'll say ready to measure, but we're not there yet, so we have to let this time run down. It's now at 45 seconds. So while it's doing that, can you go to camera 4? And let me see who is texting me. It could be somebody telling me that they're on their way or late or whatever it may be. And nope, it's just about the cases, so we're in good shape there. So basically, when you measure recirculation, you want to have your any shunts you may have on off. And so we have this turned off. And then I have a line there that allows me to increase the recirculation, take it from 0 all the way up to 70, 80%, and various different. So we're going to shoot several of these to see how this works. So let's see, countdown's almost over, and we should get it, yep, ready to measure. And now you see we're getting a green light here, and we're ready to go. There's no sense of urgency to do this. What is important is making sure any shunts you have coming from the top of the oxygenator going back in, it's off right here, are turned off. So you can actually do this and turn it completely off, and now you know it's completely off to the oxygenator, okay? But I know it's off if I leave it up, but I'm going to do it that way for now. And when I inject, if you watch the screen of the ELSA meter, not long after my injection, you will see it go into system analyzing mode, and it's automatic, so there's nothing else you have to do. Always make sure you have a dead-end stopcock here. In fact, every stopcock should have a dead-end stopcock. I'm going to inject, I'm applying pressure, and it needs to be rapid. Not super fast, but fast. About that fast is perfect. Now we can come here and we can watch, and you will see it go default into, on its own, into analyzing. Please wait, and it takes 60 seconds. We're at 50 seconds remaining. And as I said, you should never add a stopcock directly to a connector. And if I had one to show you, I think I might. Let me see if I can find one. Yeah, there's one right there. This will work. Yeah, that's all right. Let me just grab this stuff. This is just, I just want to show people this. I think it's important. I didn't hit the camera, though, or anything, right? No, they could just see me bending over. I'm sorry. Okay, so here is a stopcock on a connector. Can we go to camera? Oh, here, this is doing this. Okay, so let's do this first. So take a look. Your recirculation is 0. I'm going to hit accept because it was the first time we ran this patient. Recirculation is 0. Anytime, and this is your first line, is your oxygenated blood volume, then you have your pass to your arterial sensor, and nothing. Eventually you do see it come back to the venous and then go back to the arterial. You'll see that through the capillary bed throughout. Anytime you see a recirculation of 0, and it doesn't matter how great the surgeon believes they are or the cannulator believes they are, nobody can be that perfect. It's usually an indication, which we talked about in our scenario, of a hyperdynamic state of the patient, meaning you're only flowing 3, 3.5, 4 liters. Their cardiac output is 8 liters. That mismatch is almost exclusively why you see that. Now, We're going to remeasure, only I'm going to make some changes in my system, and I designed this to be able to demonstrate this. Okay. There you go. And it's not, you know, it's funny because I had to sort of dance around all this stuff. That's what it's like in an ICU, as a matter of fact. Usually very tight quarters. It's never you have all the room in the world. And the bigger you get and the older you get and the less flexible you get, the more difficult it is to get in and out. So we have 20 cc's. We've already hit measure. We have a green light. I made an adjustment over there. And we're going to get ready. 1, 2, and 3. Nice big injection. Goes quick. And we're going to watch this. And it takes about 60 seconds. And then I'm going to show you about these stopcocks, because that's something that I think is something that is very, again, underappreciated. It's a lot like renal failure. We grossly underappreciate renal failure in cardiac surgery. And in fact, I think when patients go on ECMO, now not everyone needs CRRT, I can't argue that, but the way I feel about it is everyone should get CRRT. There's an argument, well, you're adding something, adding complexity, taking risk by adding it. I agree with that. But I think CRRT is not used the way it really is intended to be used. Yes, it's great for patients who are in acute kidney injury, acute renal failure, but you can use it for fluid balance management. You can use it for acid-base management, electrolyte management, keeping a homeostatically normal environment. Because when you put someone on ECMO, I will tell you this, it's life-saving, but it's not good for you. It's helpful to that patient, but if I take you as a normal, healthy human being and put you on ECMO, it isn't going to be good for you at all. So you have to take into consideration that the ECMO is very inflammatory. So you have a patient that's already inflammatory, and you're going to present now another inflammatory process to them and circuitry. I think that dealing with that with CRRT is much better than giving the body and many times the opportunity will work and they will clear all of that and settle down. But why? We could clear it ourselves. You can clear lactate, you can clear inflammatory mediators. There's so many things you can do with CRRT and provide that very homeostatically neutral environment, which is going to help the patient heal faster. So let's go back and take a look at this. Look at that. The recirculation is 100%. That might have been a little extreme, so let me make it a little bit less extreme than that. I have to adjust my clamp. It's a little bit of eyeballing and guesswork. That might be better. Let's try that one more time. That result is a little too much, but it's possible with complete right heart failure, but the patient is going to be really, really unstable. Let's try that one more time. Go here. I've already hit the button. I'll give it the old injectoroo. Done. And we'll let that go. Oh, I didn't hit measure, ready to measure. Oh, somebody watching me? So as you could well imagine, the patient from me has now received 20, 40, 60. This will be 80 cc's of volume. So if they're not making any urine, you got to think about that too. Let's try that one more time. There. Okay. Should go into analyze mode. And it's analyzing. Very good. So let's go back to our stopcocks. Let's go over here. Camera 6. And maybe we can look at both me and this. Mm-hmm. Any more? Yeah, there you go. That's perfect. Dude, that's perfect. Okay. This is a 3/8 straight connector right here. This is a little pigtail, and they come in a variety of sizes with a stopcock on the end. and this fits on here. And these stopcocks have non-vented. You always want to make sure that you put non-vented on here. As I showed you earlier, you turn the stopcock the wrong way and you have air all your system. If you have it pressurized and you just get sprayed with some blood, well, you can deal with that pretty quickly just by turning the stopcock. But if it's air, it doesn't take very long. But the beauty of this is not going to break. Somebody hits this, bumps it, not going to break. Contrary to that, if you take this and you have, I'm going to take this off, and I'm going to use this as this directly on there. And I've seen it happen. This is very easy to break. See if I can get it to hold still, not spin. There. There, I broke it. It's broken. This is broken. And when it breaks, if it breaks completely off inside the stopcock, the connector, now it's cracked. And there is no fixing it. The only thing you can do, you can't even get this off. The only thing you can do at this point in time, and it's a fire drill, you need another 3/8 connector. You have to clamp here. It's going, if it's on the positive side, it's going to be a bloody mess. Clamp here. You have to do it as sterilely and cleanly as possible, and you have to connect it. So this is broken very easily. I think I can get it off. I can, but if this connector breaks or a piece of this breaks off inside of it, there's not going to be any getting it off. You can't get that out, so you can't just replace the stopcock portion. If you have it like this, it is much safer to work with. You can't do anything with it, and that's why you want that. So going back over here, your recirculation is 42%. So 42% means if I'm flowing 4 liters, which up there is 3.87, my effective ECMO flow is only 2,330. Now this can be, at that value, that can be, let's go to camera 4. That number can be indicative of cardiac failure. That number can be indicative of catheter malposition that you saw where it was in the right ventricle. It could be pulled back out. There's any number of things that can cause that as a problem. So with all of that said, I think I have covered all of this. We're going to take another short break. I know that Ann is going to be here for our fireside chat. And is there anything that you can think of? Anybody have a comment? Anybody want to ask me to go over something that I can go over with our system at this point in time? Magic? Anybody want to call in? You want me to read the number out? No? Yes, please. Yes. The number is 832. Somebody help me. 832-239-5358. If you want to be live on the air and talk to us, 832-239-5358, and I can show you some other things. In the meantime, we're going to take a short break. We're going to wait for Ann to join us, and we'll wrap up the day. How does that sound for everybody? Sound good? All right, let's do it. So, welcome everyone to our first installment of Fireside Chat. I'm here with my good friend Ann Greco. Gretchen, how do you pronounce it, Greco or Greccio?
Greccio.
It's Greccio. You know what? I've said it both ways for I don't know how many years now. Okay, so everyone knows Ann, but we're off duty. I've been doing this all day. Ann is off duty, although she's in scrubs, but she's way too far away from the hospital to do anything. So here's a toast to our Fireside Chat, okay? And in honor of our Fireside Chat, and you can watch the monitor here, things sometimes in these Fireside Chats can get a little bit out of control. And there we are. We're going to have conversations at the Inferno.
Okay, at
Yes.
the Inferno. Oh,
So
my
yes,
goodness.
conversations at the Inferno. Okay, so we'll just leave that up. And you worked all day.
Yes.
You somehow managed to, I don't know why you would do this for me, but you got in your car and you drove at least an hour to get here to Magnolia. You are, you know, and I've mentioned you a couple of times today, but since you're sitting here, you are the president of the ABCP for another
Right.
year, right? For the rest of this tenure. Your service runs for how long? So tell us a little bit about that. So I think for our audience, because we're going to be talking a little bit about ECMO,
Right.
and where this is all going and what we're doing. But I also wanted to talk about some other things, if that's okay with you.
Sure.
And maybe just kind of get the Smirnoff Ice broken and get the conversation started with, tell us a little bit more about the American Board. I think the founding of it, if you have a little bit of that history, maybe not too terribly in depth, but a little bit. And is everything okay? Mics are on? Yeah. Okay, we're good. You know, how the organization has evolved, what its mission is, and what the current structure of the board is at this point in time.
Okay. So the American Board of Cardiovascular Perfusion was founded in 1975. It actually was created to be a separate body that was credentialing only. As many of you may know or may not know, AMSECT was the first professional society for perfusion, and it actually started off with the credentialing, but quickly realized that it should not be credentialing members, that should be a separate, neutral, if you will, entity. So that's how the American Board was born. So over the years, we did, at the beginning, do some school accreditation. Again, you know, perfusion was pretty young in 1975 as a profession. So as time has gone on, that again has gotten bigger and has gone under a different organization called KHAP, and specifically the Accreditation Committee on Perfusion Education. ACPE is with KHAP. So they do the schools.
Okay.
But we basically, at the American Board, set the criteria for credentialing perfusionists in North America as getting their CCP. So again, that's that credential is tied a lot to licensing in states that have it, and also to employment. So it is a goal of perfusion education programs to have their graduates be board eligible, sit for that exam, become a CCP.
Gotcha. I have some questions about that, but could you hold this for me for just one
Sure.
second? And let me just pin this over here.
Oh, to be a little more.
Yeah, well, it's dangling, and I'm like a fish. I get distracted, you know, very easily. I think you know.
Oh, okay.
I can start looking.
I don't
around.
want to make you nervous
Yeah,
or
I get
distracted.
I'm very nervous. So the schools are governed by one body, and their curriculum is taught. I'm assuming that the curriculum that's taught is somewhat married to the board and what they're going to test on, or is it the other way around? The board looks at the curriculum and then develops the test based on that curriculum. So which comes first, the chicken or the egg?
It's really both. I mean, there is a core curriculum that the ACPE requires of their schools, and then that is a very similar core curriculum to our knowledge base in terms of areas and sections of the exam that we write questions for.
Okay.
Okay. So they are really married.
Okay.
I would assume at the beginning that was probably a collaboration, since we were accrediting schools early on. We probably basically did provide the core curriculum that we were going to test with. So again, I wasn't there in 1975, but I would assume it started that way.
No, I wasn't there in 75 either. I started in 77. When did you start?
84.
84? Yeah, so 7 years after me. Not really that far, not that far behind.
But the curriculum is, among schools, it is called the core curriculum for a reason, because all schools that are accredited by the ACPE under KHAP should all be teaching the same curriculum. That's why it's called the core curriculum.
Now, in terms of, if, for example, when I went to school, I didn't pay to go to school. They paid me. It wasn't very much, but we were considered, you know, to some degree, slave labor. Okay, I mean, I was on call 24 hours a day, 7 days a week for the entirety of the 2 years that I went to the program that I went to. There were no days off, there were no holidays, there were no exceptions. And the money I made, I didn't get very much. I mean, I think I made like $55 or $60 a week or something like that. It was pitiful, but school didn't cost me anything either.
Right.
So that's what you were, so there was no cost associated to it for me to go. And in the beginning, it actually wasn't until my second year that they started actually giving that little stipend. And it's interesting because in 1977, 1978, it wasn't much money even then, but it was actually pretty significant when I think about it. You know, and what I could buy, you know, that gave me some room to breathe and be able to get through school. But it was also very easy to fire people back then.
Right.
Okay, because you didn't pay and you don't do what you need to do.
I don't like how it's.
Oh, sure. Yeah. You can hold by spraying off ice. I don't know where it is. Okay. Can I leave my ear? Thank you. I guess that's payback for earlier. Oh, yeah. Well,
What happened earlier?
Earlier? Oh.
Don't want to talk about it, or?
The first part of this morning was fantastic. The second part of today was, it looked like the inferno behind you.
Oh. Well, I need to know the details now.
It was brutal.
Okay.
Okay, I'll go through the details with you. Thank you, sir. Is that better?
Yeah, I believe so.
Okay, good. I forgot what I was saying. That's, you know, I had a memory test the other day. It didn't go well. It didn't go well.
What? The cognitive test?
I had a test the other day. Not that wasn't full, but it was during a regular checkup. So they gave me the 3 words to remember, and I remembered them. Very, you know, she asked me, like, you know, 10 seconds later. I thought, oh, that's easy. I answered them, and then she asked me a couple of other questions, and then she asked me those 3 words again. And I was like, oh, come on, you know, I mean, that's long gone.
Really? That was
Yes.
a long time ago. You were talking about school and the stipends.
Yeah, you know, you got fired very easily.
Yes.
You don't have to be here. Goodbye. But now, of course, people are paying a lot of money to go to school.
Yes.
And when you pay a lot of money to go to school, the schools can't just fire you. They can't just say you're not going to cut it in this program because you're going to get sued.
Most likely.
So how has that, where did you see that change occur, And is that a good change that occurred? I'm assuming it was necessary because it's very difficult to educate people for free. But given the number of perfusionists that there are, is it even financially viable to train perfusionists in a college? I just don't know.
Well, when I got to my school, they had just quit offering a stipend.
Which was Texas Heart.
Right. So they were in, it sounded like they were doing something very similar to your program at the time. And again, it wasn't a lot, but it would help you, make ends meet, or you would be able to, afford some groceries or something like
Yeah,
that.
you could buy rice.
Yeah.
Yeah, it wasn't
Or
very
top
much.
ramen or something.
Or top ramen, yeah. I don't know if that had top ramen back then.
I remember top ramen.
Oh, really?
In school.
Yeah.
But anyway, so they had done away with that, and I think it was just part of the evolution of perfusion education, becoming more mainstream, more organized, more professional in terms of how it was going to be taught, who was going to teach it, raise that credential, raise that level of education, because you see it now with master's programs in perfusion. It's the goal is always, one of the goals is always to advance your credential. You see that in the CRNA realm a lot.
Yes.
That's actually been a master's for quite some time, and I think it's going to a doctorate.
Yes.
Yeah, so I see that same progression.
And we have doctorates in perfusion. But does that make sense? I mean, I can't ever criticize education, depending on, I guess, what pathway you want to take or what you want to do. But I can't imagine we need too many of them.
Well, and I think that's also, and we've had this discussion among our board directors in terms of, does the market really support that in terms of, everybody needs a master's right now. What is a master's in perfusion? I'm sure some of our schools that are offering it could weigh in and chime in on that. But what is it? Is it a fellowship in pediatrics? Is it something in ventricular assist devices? Or is it just writing a paper? I think we need to really work with the ACPE on understanding if the requirement is going to be to go to master's level, that really needs to be standardized what that master's level is. And just because of going to a master's, you do have to be affiliated with the university. You have to have a PhD oversight over that program. So that's the way that it seems to be going. Whether or not some of us who've been around a while think that is worth it right now, you don't see that. I mean, any perfusion graduate of any accredited program is probably going to make the same, depending on where they are in the country. But between a master's and a non-master's student, there's going to be really no difference in their starting salary.
Well, yeah, and pay is one thing. I mean, it's an important characteristic of all of this. But, in addition to that, does it really give you any different standing? In other words, perfusion and perfusionists are an integral part of the cardiac surgery or ECMO team. You're a part of a team. But as far as being a, decision maker, there are things we do individually in the conduct of a case that we are making decisions very independently. But at the end of the day, we're not MDs. And unless you are an MD, it doesn't really matter how many PhDs you have. So you're certainly a stakeholder, but you aren't the decision maker when it comes to what are we going to do on this case? How are we going to do this case? Well, I find our jobs to be very elegantly technological in nature. And the primary thing that we do, now we need to understand a lot. We certainly have to, because again, on bypass, you're it. Nobody really knows what you're exactly doing there. but everything is done with the understanding that whatever it is you are going to do, there is a physician, usually the heart surgeon, who is in agreement with it. You may not have to ask in the moment, but if you're not, whatever you're doing with the understanding that that is part of the protocol. That's how you would normally handle this. I say it all the time. You're only as good as your last right decision, because we're not physicians.
Right.
Physicians are far more easily forgiven for sins of the mind, making a mistake, an honest mistake, that could result in a less than optimal patient outcome.
Right.
We have none of that forgiveness. You mess up, it's usually the last case you ever do. If you get sued, it's usually the last case you ever do.
So the stakes are very high.
Very high. Very high and very different. What are your thoughts on that?
Well, again, we are part of a team, and we are, for that time that you are managing the patient on cardiopulmonary bypass or ECMO, you're in control of that, but you're also in conjunction and joined with your surgeon, your anesthesiologist, your scrub tech or nurse. You're joined with everybody, and of course, all for the benefit of the patient.
Sure, absolutely.
So again, what does it matter if you have an elevated degree? You need to know how to do that and do that well.
Right.
And be
you
able
can do that
to
with an associate's degree if you're really good at it.
Correct. And that's where I think we kind of wonder, the elevation to masters, it needs to have something value added to it in terms of the perfusionist and their role. Does it equip them to better be a VAD coordinator, an ECMO coordinator, more of an administrative role in addition to their clinical role? Maybe. Does it help them be more recognized among healthcare
Peers. I don't think so.
I think it depends.
Do you?
Yeah, I think it
Tell
depends.
me why you think it depends, and I'll tell you why I don't think so.
Okay, because if you decide that perfusion is your path, and you get your master's there, okay, and again, currently I feel the master's is varied in terms of what's required to achieve it, but you have done something more in your education. You've qualified as a graduate of an accredited program. You have met the qualifications to take the exam. I don't know if the master's equips you any better, but you've satisfied what we require to become a CCP. And that really is just based on graduation from an accredited school with a certain case requirement met, and of course, passing and signed off by the program director. So whether or not that happened at a certificate program or a master's level, it's of no difference. But I feel like if you are getting that master's, that you have done something in addition, while it doesn't make a lot of difference in terms of acquiring your CCP, I feel like it equips you to either, one, be motivated to do more in perfusion other than just doing the cases. Maybe gives you a bent into research or an avenue to participate in that. Quality initiatives at your workplace, depending on your employment model. I feel like it gives you a little more credibility to actually give back.
You know what? I have nothing else to say because I agree with everything you said 100%.
What? This is a first. He never agrees with me 100%.
That was so well put, and so, I mean, that was very concise. It made a lot of sense, and I don't have a good argument, even just to be controversial.
Oh, come on.
For this. No, I mean, I really don't. I think it just depends on what you want to do. I think there is room in the market for both. So my view is it should not be mandatory. My view is that I think a bachelor's is a minimum. I don't think that you should only have an associate's degree, though if you're really good at what you do, that's okay with me too. But I think you have to have a minimum knowledge base that you're not going to get in that without going at least through a bachelor's in science with chemistry, biology, physiology, all of that stuff, physics, that we need to do our job. So I would say that's the minimum that you should have. I think if you want that as a pathway in order to do things, then by all means, I value it. I think that is important, and your reasons for doing it make a tremendous amount of sense. But I think that the person who has no interest in that, but wants to be a good soldier, a great grunt, a great technician, to do a great job in the operating room for the cases that they do, that don't want those other roles or responsibilities, I'm okay with that. But if you mandate it, then they have to. It makes it more expensive. There's only so many of those. I guess now it could be the flip of that. The market as it currently exists doesn't have a lot of opportunity. If every perfusionist was a master's level doing theses and so forth, probably the market wouldn't support it. But if that was more the norm, then the market might change to accommodate it, because one usually adapts to the other and back and forth. So that very well may be the case. But you can only have so many chiefs.
That's true.
You can only have so many people doing research. You can only have so many people spending their time doing education things, though I think you can do it as part of your regular day, but you really do need people who like to do a lot of cases. So I think you need both.
And do you think that it prepares someone to be a good affiliate location?
Oh, well, now that's a very good, I mean, that's such a very good point. A person goes to an affiliate program usually to do cases, right?
Right.
They're learning their didactic theoretically in school. Does everyone at an affiliate program need to be a master's to train students? No, I don't think so. Should you have one in the department, perhaps, that's the overseer?
Right.
Like if you want to be a department head in a major place, if you're just going to be chief of 2 people in Tuscaloosa, Alabama, you don't need to have a master's there. But as an affiliate program, you would have to have that. That is part of the requirement. And that is the benefit that the maybe fewer number, or those that choose that pathway, then have the opportunity to utilize that skill, because they're the ones who can fill that need, which would come with an additional compensation to accommodate the higher degree and the position that they have within the organization.
Because, I believe that it sounds like, or we get the impression that more just working perfusionists would like to be affiliates for schools. And, some schools at times struggle with getting their cases for their students, and they do have to send them out. Many programs actually not depend on it, but it's a big part of how they train their students is through affiliates.
And that is so that's so different
Yes, it
than
is.
it was many years ago. I graduated from school having done 300 cases plus
Right, in one location.
in one location.
As did I. And it was really interesting over time to meet people that had been through programs that were almost all affiliate-based in terms of their clinicals. And I just didn't realize, you know, how not unique, but of its time, we were, that your didactic occurred in the same place you did your clinicals.
Right.
It was all the same. But it seems to be more and more rare.
Yeah, I agree, and I'm not sure that's a good thing.
Well, you know, I do have a coworker, and she does some work for you too, and we've talked about that because her training was definitely affiliate based for the clinicals, and she enjoyed the advantages of different circuits, different ways to do things. You know, you sure learn in a hurry how to get along with people because you are going to a site where who knows what the staff dynamics are, the surgeon dynamics. So she thought it was very beneficial and a wealth of a good way to train. You know, when I trained, and maybe when you did as well, we did pediatrics and adults in the same
room.
In the same rooms. And that is unheard of these days.
Absolutely.
And so I don't feel that we had a different experience for sure, but I don't feel that I felt like we were still exposed to, you got to build a different circuit now, you've got to pick different things, you know, from doing a 5-kilo baby to doing a 150-kilo adult, you know, and you saw your valves, you saw the aneurysm work, the aortic work.
Yeah, you got exposed to everything.
Yeah, you
didn't have to go anywhere to be exposed.
Right,
and not
it was all there.
And not everywhere you go in these affiliate programs provides a lot of that. So yes, you learn to get along with people very well if that's your personality. There are people in this world like me who are far more likable than others, right? You know how to not be abrasive like me. Again, you know, all of this is about me. The whole thing's about me. But there are other people who, you know, if I were a younger man, knowing myself when I was younger, and if I were in that same circumstance where I was having to go someplace new all the time and reestablish those relationships, it would have been a very difficult road for me. And I think there's a lot of people who are very good at what they do who may not have the right personality for that. And it puts them at a real disadvantage. So if you are that kind of person that is very chameleon-like and can just adapt very easily to a new environment and just is one of those people that everybody always likes, and there are people like that, you're fine. But if you're one of those people that takes a while for you to kind of, you know, for people to kind of get used to you and warm up to you, your time is up before anybody really gets to know you and like you enough, and your experience there may be very, very, very different. Where if you're training, you're doing everything in one place, the educators, everyone has a vested interest in you, and they have gotten to know you over that course of time. And so it makes the learning, I think, a better in that circumstance. Now, if it could flip, it could go the other way. You don't get along with anybody here, but you go over there and you got along with them enough. So the affiliate program also,
could be a way for you to actually blossom or
and
thrive.
reinvent yourself.
Yeah.
Sure. So I'm sure for every negative that I could find, there's probably a positive in there somewhere as well. So you know, it's there's no perfect system. I think that's what we're determining here.
Right. It could be done a lot of different ways, and you know, you've encounter fantastic grads, you know, from all different ways, and they certainly, you know what they're doing when they're being trained correctly,
well,
and well. So.
Yes.
Who's to say, you know, what is there a best way, or is it just being adaptable and flexible? Obviously, in our jobs is really important. But at the same time, I was just kind of amazed to hear some stories of students going out to their affiliates, and maybe that's the first time they've perfused on a human being. And, just that stress level to me, I was like, wow, how would that's right up here.
Yeah, that's right up there.
Yeah.
That's right up there.
That's stressful.
And it's so important to have good instructors. It's so important that the faculty in those circumstances are people who are there to really invest in another person who they may not know's success.
Right.
And it's so affiliate programs are critical, I think, in terms of having the right kind of people, not necessarily the people with the highest degree, but the people with the highest level of communication and able to maintain their composure while someone learns to do something that is so incredibly important and critical, because you can really make or break a person in those circumstances, I think. So again, I think when you're familiar with a place, you get in trouble and made to stand in the corner or get kicked out of the room or get fired and rehired in the same day 3 times. You know those people and you kind of get used to it, and you sort of know what to expect. But when you're someplace new and somebody gets flustered or frustrated with you and they snap at you, and you have to stay there another 2 months.
Right.
That can be real hard to do.
Yeah, and we've talked about your favorite phrase, there's no crying in perfusion.
No, there is no crying in perfusion, but good Lord have mercy. I know you've told me that you know some people that are coming out of school that are so really talented and good. But I gotta tell you, man, I've heard a lot of crying. I've heard way too much crying. In fact, I was opining about that earlier today and talking about, just the younger generation and what the heck they're thinking and who makes, the kind of money that we make. I don't disclose exactly what it is, but I have a very comfortable life. There's no, you're only, and some people are making this and working 25 to 30 hours a week, maybe. There's not another industry in the world that you can make this kind of money and work that little. Now the call, that's a pain.
Right.
But we don't get called that often in the middle of the night. It's not that frequently. Now I don't have to do it anymore. I've done plenty of it. So it's a little easier for me to sit on my perch and it's not that bad. But I remember getting woken up at 1 o'clock in the morning. We've got a type 1 dissection and be like, no, I don't want to go. I cried, I did all that stuff.
Right,
But
like,
you just
oh,
get
man.
yourself up and you go in and you put your happy face on and you go to work.
Right.
And you do it. You may do that on the way there, but you don't do it while you're there, because everyone else that's there
Right.
likely
Would rather
feels the
not.
same way.
Right. Would rather not be there as well.
Correct. Okay, so we're supposed to talk about ECMO.
Okay.
We've thus far talked about everything but I do have to ask you, I heard, and I don't know if it's accurate or not, I want to make sure that I don't pass along inaccurate information, but I heard that they have opened 12 new perfusion schools. Is that accurate?
I know of 5.
5, okay. You would know. So the 12 is just an exaggeration from somebody.
Well, unless they're going back a little bit and putting it all together, but
Okay, the past 2 years.
5 to 7,
Five
maybe
to
7,
seven.
maybe
Seven,
7. If you
okay.
want to take 2 that have been going for a little bit here.
How many have we lost?
2 that I can think of.
So we're up a net, so we're up 3 to 5. Okay, and any further on the near horizon?
Not that we've heard officially. Part of our collaboration with the ACPE is to, be notified when a school or program has applied for candidacy.
Okay.
Because there's a lot that goes into, you just don't start a school.
So KHAP has to tell you versus the school tell you.
The school has to apply for candidacy
Through the ABCP or KHAP?
through KHAP.
Through KHAP. Then KHAP has to inform you.
Well, we would hope they would, and they
So they're not obligated to.
but we have a very good relationship,
Right,
so they
but-
do.
Yes, they do, but it's not like a requirement. They just do as a courtesy because it's
Correct.
appropriate.
Right.
Okay, so a school could technically open up without the American board knowing it.
For a time.
Okay.
Again, you know, once you start getting an application for exams, you're going to know that they exist, and you're going to have to know that they're accredited by the ACPE, because
Okay.
that's the only way those applications are considered credible to apply.
Okay.
You've got to meet that.
Okay, yeah, it's a convoluted system.
So we would have to
But I kind
know
of understand it.
that they were an accredited school.
Right.
And candidacy is required by the ACP at this time. Okay, there were in the past a few situations where schools would open and get running before they would formally seek candidacy.
Well, I did. You know, the school I went to, of course, we were the second accredited school. So the whole thing about our school, and just to clarify it, was Billy Applegate and Charlie Reed were close friends. Charlie taught Billy. Billy started the school in Tucson. So when I was starting my second year is when Charlie came out and did the site visit of the program. So the program I went to was not accredited. Now, at the time, it didn't need to be accredited
Correct.
for me to take the board.
Right.
But they wanted it to be accredited before I took the board, which in fact happened. So you were Texas Heart, THI. We were Tucson Heart, THI2. Or another THI, like the restaurant Broken Egg. The restaurant Broken Egg is from Mandeville, Louisiana.
Okay.
And it was on Lake Pontchartrain, on the north shore of Lake Pontchartrain, and that's what it was called. It was called the Broken Egg. Well, they decided to franchise it. But instead of franchising it as the Broken Egg, they franchised it as another Broken Egg. So when you see those restaurants, another Broken Egg, the original is in Mandeville on the North Shore. Now it got destroyed at Katrina. I don't know if they ever rebuilt it, but that's where it originated.
Oh, okay.
So there's the story of another Broken Egg.
Yeah, so
They're very good.
are you another THI?
So
or-
we're another THI, yes. So you have THI, and then we have another THI, right?
Gotcha.
And that's how now that school doesn't exist anymore. It closed down in, I want to say it was, Billy died, I believe, in 1996 or 97, no, 95. Billy died, I think, in 95. And they tried to keep the school running, but he was the school, and it just withered on the vine and just didn't make it. I think they did like 2 or 3. So they only took one student per year. So you had a first year and a second year.
Okay.
When I went, there was no junior. It was only one student per 2 years. And then
Wow.
they changed it to one junior, one senior.
That is so small. No wonder you were doing everything.
Everything.
Was it because they didn't think they had the caseload for you, or they just didn't have the personnel for the?
Yeah, they didn't have the personnel.
Okay.
Yeah, it was Billy Applegate and Bill Gabriel. Bill Gabriel was a graduate of Texas Heart,
Okay.
and him and Billy were partners. The surgeon was Adib Sabah, was his name. He was an Iraqi from Baghdad. Interesting fella. Acted just like it. And there was just 2 of them. And so between the didactic and the clinical, but you did, like I said, you did everything. But I don't think the infrastructure was there, is what it was.
And then no succession plan to
No.
keep it going.
No, there
Yeah.
wasn't.
Yeah.
I think they always wanted to stay like that, very small, very boutique-ish, very intense training. I have to say that anyone I know, do you know Paul Shuttleworth?
No.
He's out in California. He's up at Stanford.
Okay.
If you don't know Paul, but he's an excellent perfusionist. And he's done very well. Anyone that came out of that program, I think, did extremely well. But he came out, he was 2 students after me. So I graduated two students after me. He went to that program, and he ended up in California and did very, very well, very well. But I think that was their whole idea, was we want people to leave training that can go do a case
Anywhere.
the very next day, anywhere, and be highly competent. But again, it was over with in the, whatever it was, 93, 95, somewhere around there. So it lasted from 77 until 77, 87, not even, about 18 years.
Well,
And then the
that's
school
not a bad
closed.
run.
No, not too bad. It would have been nice to have seen it continue. Now, University of Arizona,
Right.
they picked it up, not as Tucson Heart Institute, but their own program. And now they have that
Right,
program
and that's
there.
it's a great
David
program.
Holt.
Yes.
Yeah,
Yep.
and he has that course that you can take. One of our friends is taking that course right now, that's coming back into industry to try and retake their boards and be able to pass them. I don't think there's any doubt that they will, but he said that David's program is a very good program and has a lot of information. And David, of course, he's a PhD,
Okay.
extremely bright, good perfusionist. So I think that he certainly has demonstrated. Look at Julie Wagner. She's a PhD, right? Is she a perfusionist? She is a perfusionist too, right, Julie?
I
Or is she-
believe so.
I believe so too. I don't know why I'm wondering about that. And then there was who was that girl that was up at Ohio State? Started with an S. I can't remember her name. I don't know. I can't. She ran a course up there for board preparation as
Okay.
well at Ohio State. But they had a school there that
Right.
closed down.
Yep.
So I think I don't know too many other PhDs. I know a few, but not too many. It's pretty rare.
Yeah. There was one on that served as a board director for a time, PhD in education.
And that's
a
the question,
perfusionist.
what PhD should you have?
Right.
A PhD in perfusion or a PhD in education? That's another thing. And then remember Tabby? Tabby's, she's a perfusionist, but she has a PhD and she's doing post PhD graduate work on top of it. And she's extremely bright. She's a very, very, very smart person, much smarter than I'm ever going to be. But she's also a perfusionist, but she has a love and passion for research.
Right. Right.
And teaching, and that's what she loves to do. I enjoy it too, but I like it more in this format than the more formal format of an actual school, because there's all kinds of teaching that you can do.
Oh yeah.
Okay, we have 5 minutes left to talk about ECMO.
Okay.
Where the hell is ECMO going?
It's here to stay.
God, dog it. Oh, I didn't want to hear you say that. And
Well, I
please,
mean, everybody-
say it isn't so.
Everybody knows what's been happening over the last 2 years. And I just think that the awareness of that therapy is just going to be long lasting. Again, not necessarily for every pandemic that comes along, but
Monkeypox.
well, right.
We can heat you up. Put you on ECMO and heat you up. Do
But-
therapeutic hyperthermia. I've tried that a few times.
I have no idea if that's considered a therapy for monkeypox right now.
Maybe not from, well, you never know. I mean, you don't know until you try. Let's just heat people up, cook them. We'll do a couchon delay. Yeah, that's what they call it, right?
Oh my God. Well, we do have the Inferno behind us, so
We do,
yeah,
yes.
it's all about
Exactly.
hyperthermia.
Yeah, I'm feeling the heat.
Yeah, the heat. But I just feel like because of that experience and the way that that therapy was utilized, it's on the radar in terms of something to do for patients.
Well, it's so interesting. I was told during, immediately after, when the pandemic was still ongoing, but kind of, we saw the light at the end of the tunnel, and it wasn't a train. God knows we saw a lot of lights, but it was definitely, we just kept getting knocked back out the tunnel on the other end, planted to a train. But I was told by a hospital, we have absolutely no interest whatsoever in being any kind of regional referral center and doing ECMO and blah, 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 blah. And that was probably, what, 12, 14 months ago? Maybe 8 to 12 months ago, somewhere around there. I don't know, whenever, I've lost track of time through all of this, whatever time it was. I had a meeting with them just the other day. Well, we've made a decision that we're going to be a regional referral center for ECMO, and we're going to start a PERT, I don't want to say a PERT team, but a PERT program, which is the PE response team, which is going to require to have ECMO readily available all of the time.
Right.
Et cetera, et cetera, et cetera. So now, from we have no interest in doing that to, well, we're going to be a regional referral center for ECMO patients. So, what happened? Don't you remember this conversation? Yeah, kind of. Okay, well, we have to move forward, and this is what we're going to do. My concern is that I see and have seen things like this before. I've seen, and I say PERT team, I know it's redundant, but it's just easier for me to say. I've seen these PERT teams before. I've seen them come, and I've seen them go. I've seen the big investment in it, and setting everything up, and all of the training, et cetera, only to watch it wither and die, usually because of horrible judgment on the part of the medical practitioners who are making the decision who's going to be put on ECMO, and then not being able to make a decision about, we need to end the care of this patient. There's no chance of survival. So what say you?
Yes, I've seen that. And, I've talked to people who, they're in pretty outlying kind of community areas that say, hey, they came to me and they want to start doing it. And then you talk about what that entails, and you need a medical director, so people, I say ECMO is a 4-letter word, because people don't really understand what it involves when you say it.
No.
It got a lot of attention in probably the lay community. People know what they've heard that word before throughout COVID, of course. I just read an article in the paper last Sunday about someone who had been in a rural area in Missouri, ended up in St. Louis on ECMO, and it was just kind of describing what their life is like now. They still are on a oxygen, tank, but maybe getting better. Maybe we'll be able to recover fully, but just how long it takes and what it's done to their family, and but at the same time, he's also walking, surviving, and has, he's going to see his 6 kids grow up for a while, and does have a portion of his life back. So, you...
Questionable quality, but
right.
Maybe not the best quality of life, but it is life.
Right.
And, and it is precious, I do understand. And, I am a little bit concerned, and I don't want to be a disservice to the community at large, but I think that people hear things about ECMO and it's life-saving, and they sensationalize it. But for every one of those patients, there's a lot of death and destruction, and a lot of despair, and a lot of pain. And I know that, we go through that to save one life. But the question, of course, is our selection, and who do we save, and what is considered saving a life, and what life do you want versus the life I want want to accept or somebody else wants to accept. And we don't have any of those answers. And to spend the rest of your life doing this because you're not a lung transplant candidate and every once in a while having to use oxygen, yeah, you're alive, but I don't know that I want that. I don't believe so. I think that, you know, we've seen, you and I have both seen, and, you know, whether it be us in our industry or whether it be military people, you know, law enforcement people, certainly people that work in funeral homes. We've seen a lot of death, and we've seen a lot of sad deaths. But it is a process of life. It's something that's going to happen to us anyway, sooner than any of us actually want. And the real question is, are there fates worse than death? I think that's the question ultimately, and that's only a question that an individual can determine for themselves.
Very
not something
individual.
we can determine for someone else.
But again, so it brings to the forefront the structure for your ECMO program. If you're going down the road, it is better structured instead of a knee-jerk that we've done everything, but let's do this. You know, where's that medical director? Where's that team that does have an algorithm for patient selection, that looks to the literature, to the established programs that, you know, through ELSO or Platinum program, or, you know, who have achieved a level of success? You know, what are they doing? And, you know, at least to me, that seems to be the more thoughtful approach in terms of, if you're going to do it right.
Such a good point, Ann, and it's one of the things that we deal with all the time. Someone puts the ECMO in, it's post-cardiotomy. I want this. This is how we're going to do this. They're gone. It's the middle of the night. Intensivist walks through. Well, I'm going to change this and this and this and this. And then we get into a long-term situation. And they're done for the week, and another intensivist or the next shift comes in. No, we're going to change this to this. This is how we're going to do this.
Right, you're
And then
reinventing it all the time.
Yes. And I would say that a message I have to our audience, and a message that I wish people could see me and tell me and listen to me, you have to have a central decision maker about how you do ECMO. You cannot have 50 or 5 or even 2 cooks in the kitchen.
Yes.
You have to have, this is what we're going to do. This is the plan, and have it written out for this patient, and people can't change that unless it's necessary, medically necessary, for the circumstances that may have changed.
Right.
But this is what we are going to do. This is how we're going to do it. We're weaning. No, we're not weaning. We're weaning. No, we're not weaning. And we're going up. We're going down. We're going up. We're going down. You got one person telling the family, I'm seeing some signs of improvement. And the very next shift, I really think this may be hopeless. How do you do that?
All right, it's way too much of a roller coaster, and it doesn't benefit anybody. The clinicians are frustrated that are, you know, bedside, you know, the nurses, the ECMO perfusionists or specialists, because you're just getting conflicting information, and it doesn't seem to be driven in a way that's, I don't want to say useful, but that it doesn't seem to make a lot of sense. What's the plan? No one knows the plan.
What's the plan, Butterman?
Yeah.
I'm telling you, it is the biggest problem that we have. I have seen orders change within hours of one direction to another, and then back to the original direction. I've seen them change 4, 5, 6 times within the course of 2 days. And you can't, you know, we're going to extubate and trach. No, we're going to keep them intubated. We're going to wake them up. No, you're going to paralyze them. I mean,
right.
You know,
It's like,
on.
well, what are we doing? Right. You know, it's the change is just sometimes minute to minute, and it's just, I don't know what we're doing
Right.
here.
And that's the biggest problem is that if you're not an ECMO center, if you don't have established protocols, if you don't have a director where can have a designee who, however they're going to run it, but you have to have one person who has to be in charge of that patient. Maybe it's one or two people that work collaboratively together.
Right,
Whatever
but
the
at least the thought
circumstances are.
process is the same.
Yes, or some committee that there's 2, 3, 4 people. This is what our plan of action is going to be. Because the way we're doing it right now, I feel, does not maximize the effectiveness, overuses the technology in patients it shouldn't be used in, and results in issues occurring that don't need to occur in the course of the patient's course that may not be positive for the patient, because we're always making these changes. So the effectiveness of the program seems to be compromised. So you have to have all of that. It's a real commitment, and then it's a staffing commitment. We just depleted the blood bank on a patient that was severely thrombocytopenic and bleeding severely, and we emptied the blood bank. This is Houston, Texas, and we were flying blood in from Beaumont.
Wow,
That's a lot of blood.
that is a lot of blood.
We went through a lot of blood. So in a smaller, more rural program where if you don't have it, the patient's gonna die. So I understand they want it, but they have to understand that if you have it and you use it, there's a lot of cost associated with it that's worth it and rewarding when you save someone. But it can cripple you as an organization because you have it on, you own this patient. What are you going to tell the family member? We're going to turn it off? Family, you can't just do that.
Right, once you go there, you're committed there, and then there's all the legalese and who's medical power of attorney, what's going on there, who's going to make those decisions, and all the while, the care must continue.
And you think you want to get we're just going to put it in and transport the patient. And you have these arrangements with these hospitals, these big medical center hospitals, until they tell you, we don't have a bed, you got to keep them.
Right.
We'll call you when we get a bed. 46 days later. And then who's going to pump your cases? Who's going to stay up all night? What are you going to have to bring perfusionists in or specialists in if you can find them?
Right. It takes a lot of thought and a lot of preparation and just a lot of contingency planning.
Absolutely. Absolutely.
Yeah.
Yes. So, it makes me wonder. We talk about this like people used to talk about the ventilator. Is it going to come a day when, just put the patient on ECMO, we'll be fine? I wonder if we'll get there.
I don't know. I mean, you saw some of that going on in just your experience.
Yes, yeah, but it's not quite like going on a ventilator.
But they went to ECMO first.
They did. We didn't put them on the vent. We didn't intubate them.
Right. With
the belief that was going to, that was very dramatic. That was unsettling to see a patient writhing and just trying to desperately get out of there while they're putting this big line into their IJ, trying to hold them down to do this. Because they didn't want to be intubated, but they were agreeing to this. Do you know what you were agreeing to?
Right. Do they know?
And we couldn't put them to sleep because that was gonna tip them over the edge.
Right. So, education and understanding.
I'll tell you what, that whole thing, I have PTSD for that whole event, and I'm never gonna really recover from it, I don't think.
Well, and, just walking ECMO patients.
Oh, yeah.
You never thought, I never thought I'd see that. Just the way they get, the cannulation strategies now. It's all evolving, which is why I'm saying I think it's here to stay, because as it evolves, the things that we struggle with, or the things that, are barriers, or the things that, are predictable for maybe not good outcomes, they're finding out more and more about how to do that different. And new technology comes to the market. I mean, the dual stage lumen, that cannula was a game changer.
Yeah, I have one sitting right over there.
Yeah, it's,
It is, and that crescent where it goes into subclavian is so much more stable and you can really walk them a lot easier. The one that goes, when you put it in the right IJ and the lines are up on the head and looped around and stuff, it's very uncomfortable for the patients. This seems to be a lot better. You have to worry about, you know, venous drainage out of the arm, some venous congestion, and also losing your subclavian artery from compression. But by and large, it works really well. You can address those issues if you need to, but maybe it's better to put a graft on or something like that. I'm not sure, but you know, it works pretty doggone well, I have to agree. I also want to talk about the incredible durability and the determination of some human beings. I've seen it, you know, where they have literally laid there and died, but then I've also seen them taking those first few steps on ECMO. They haven't been out of the bed for, you know, 2 months, and their poor little legs are so skinny and emaciated, and they're so determined, and they take those first 2 steps, and that's all they do, and they're exhausted. And then 3, 4, 5 days later, they're walking 100 feet or 50 feet at least, and they're just so proud of themselves, and they have that will to survive that is just unbelievable. But as durable as they are, I've seen them that they're so fragile. You can do so much to them. Yeah, I've made this comment, I've joked about it. It's really hard to kill a human being, but you get to a point, and they can take it. Anything past here, gone. And we see that with our patients. I've seen them come back from, how did that person survive?
Right.
But you take that same person and you just add one more little thing, and off the cliff they go, and there's no coming back.
Right.
So incredible. So their durability, it's a dichotomy of durability and fragility.
And just human spirit.
Yes,
And
plays such a huge role.
Yeah, determination. You know, because you know, in that article, anybody can go on the Chronicle and read it. You know, they did really cite the difference in the recovery when family was able to be there. You know, to be, you know, you walk in some of those rooms, and I know our audience has done, you know, seen this, where pictures of their family everywhere, really trying to just, you know, bring it home, the FaceTiming, you know, anything to keep them connected to their life.
Yes.
You know,
so they don't develop that psychosis.
Right.
Just because ICU psychosis is real.
Right.
And that helps to, you know, keep that from occurring. Hugely beneficial.
Right. And again, and just the, you know, the care teams are wonderful. You know, nursing's wonderful. Everyone's there to try to, they want a good outcome. They want to see them recover. But when your family's there, and you know that it's real. It's real.
It's real.
If they're cognizant, they're awake, you know, not, you know, totally, you know, sedated. And even if they are, hearing's last thing to go, they
that's
say.
Right. Hearing's last thing to go.
So if they can just hear them, hear that voice that they.
I need to remind people of that when they're putting me either in the oven or they're lowering me down. I might still be able to hear magic.
Don't say anything.
Don't say anything yet. Okay, wait until I'm really like the dirt's all covered, or I'm not going to be buried. I want to be cremated.
But just that connection with real life, your family.
Absolutely.
It's huge.
Well, I hate to cut this short,
Okay.
but I think we're there. And I do want to show you a little bit of the studio.
I want to see Sim Man.
That's Sim Man right there.
I want to know.
He's right there.
I want to see it.
Show you about Sim Man. David's going to, I'm going to put a couple of things back so you can just take a short break and set it up like we're doing the actual simulations,
Okay.
so that you can see how the system works. Because even though we can do this in person, and we have chest tubes, we have a Foley in, we can put a trach in, we can do different cannulations. All the cannulas are under the drapes in the belly. You can take the drapes off and we open the belly up, and we make all the connections there. They run out the back underneath the table. And I just left it like that so people could see the ECMO simulator that we have from Eigenflow that does a variety of things. You can make the pump chatter, you can vary the flows, increase inflow resistance, outflow resistance. It's got a little computer monitor that can do different things like oxygenator failure and stuff. But I also have a patient monitor simulator that's a lot more sophisticated than that. That works very well, but this is like really over the top, and a ventilator simulator. So David's gonna set all that up. You can take a short break.
Okay.
And then when you come back, we'll have it set up just like we would ordinarily have it to do an actual sim case. And we'll just sort of run through one real quick.
Awesome.
Sure. Okay, well, I want to thank everyone, and I want to thank you so much. You were
Always
here
a
for our
pleasure.
Raging Inferno.
Yes.
It's our inaugural, so this is great. I had to write Fireside chat. Can we go back to the Fireside chat so we can end this on the on that,
Instead
David?
of burning up.
Yeah. Please?
No.
We can't? For
I had done it.
you dumped it?
I'm trying to save our system from dying, so I had done it.
Oh, he's trying to save the system from dying, so we're stressing the system.
We have way overloaded.
We've overloaded the system.
Lucky we are still on.
Okay, well, this is just a little out of control fireplace for the board, because I have to list this as a fire, I know you're president of the board, so I'm sorry. We list it as a fireside chat so that, but it's, we really call it Conversations at the Inferno.
Okay.
It's really what it is.
I like it. I like
Yes.
Conversations
It's a
at the
little-
Inferno.
Yes, it's a little bit different, and I think we could, this format would be very useful for just telling stories. And we're gonna get some different chairs and things like that. I think David's working on making this part a little bit better, but that's a pretty cool green screen.
Oh, yeah.
I painted the wall green. I
See?
painted this myself.
Wow, nice job.
And so, yeah,
Well done.
I did pretty good, 4 coats.
Yeah, I was going to say
It took
it's
4
really
coats.
green.
I didn't do too good up the top.
Oh, yeah.
But Magic did that part.
Blame it on magic.
Or the edges over there. I didn't do too good
Now,
over there.
see, that's my favorite part of painting. I love to cut in along ceilings.
Dude, I can't do that, okay? I'm not a painter.
Okay.
Like, I'm not a painter. You know what I do really well? I clamp tubes.
Okay, I like
I'm
that.
a real good, in fact, I can spin tubing clamps, I can
Oh, wow.
do all
We're going to have
kinds
to
of
have a
stuff.
little
I ha-
demonstration of your clamp skills.
Oh, my clamp skills are pretty good.
Okay.
I've got some skills when it comes to clamps.
I want to see it in like a gun, like put it in your
Oh, yeah.
holster. I want to see.
I can do that too.
Okay.
And I can pull it out, open and close it, which is simulating firing it, spin it and put it back.
Okay, that's how you need to open this next time.
Okay, we'll
Okay.
do, that will be the opening.
Yeah, and
That'll
we
be
can
the
play
opening.
some of them, doo-doo-doo.
We'll have to do some, that's
Some
right.
Western music, yeah,
That's
yeah.
right. I want to be, if I'm going to be anybody, it's going to be Clint Eastwood.
Okay.
Okay, if I'm going to be anybody, it's going to be the good, the bad, and the ugly.
Okay.
Right, or whatever that guy's name. No, who's the other guy that he was the, who was that, what was that one where he was going out into the wilderness and he got this granny and the Indian guy and the daughter of the granny and they were going out and, huh?
Bruce Chicago, John Wayne.
No, it's
More
Clint
recent?
Eastwood.
Well, that one,
And he spit on the dog all the time.
Hale Rider.
No, it wasn't Hell Rider. I can't remember. We'll figure it out. All right, we'll tell y'all later. We'll see you next month for our next installment of PerfWeb. It'll be PerfWeb
August 22nd.
83, August 22nd through August 25th. We'll see you then. Thanks for joining us. Good night.
Bye.